Testing. Okay. Good afternoon, everybody, and thank you for joining us. I am Alan Santana, paralegal at People with Disabilities Foundation, or PWDF. Today's seminar, Psychiatric Disabilities in Older Adults, is PWDF's 18th open public seminar related to psychiatric and/or developmentally disabled individuals. PWDF is a Section 501c3 public charity founded over 24 years ago with a mission of total integration of people with mental and/or developmental impairments into the whole of society. In addition to seminars, our education and public awareness programming includes producing training videos for human resource directors, vocational rehabilitation counselors, and disabled individuals. We also have an advocacy program covering 8 San Francisco Bay Area counties, primarily involving Social Security issues and disability rights. Our mission focuses on total integration of people with psychiatric and/or developmental disabilities because they are some of the most marginalized groups in society. Within these populations, older adults face additional compounding marginalization. We chose this seminar topic largely because we did not see it touched upon in many places, despite it touching many of our own lives. The proportion of older adults aged 65 and older in the U.S. will rise from 16 to 23% over the next 40 years. Thus, the topics discussed today will only become more pressing in the coming years. Beyond the challenges of physical health, changes associated with aging, it is important to understand mental health issues among older adults and how those may impact one's quality of life. According to the U.S. National Academies of Sciences, Engineering, and Medicine, mental health issues range from serious mental health disorders such as major depression and vascular dementia to declines in cognitive functioning or dementia such as Alzheimer's disease to addictions. We encourage audience members to participate throughout the seminar, but please wait for the microphone to be brought to you. If you're watching via live stream, please feel free to submit questions through the comment function in YouTube. If you are attending for continuing education credits, please make sure to sign in on the proper form at the registration desk. Turn in your evaluations at the seminar's conclusion and get your certificate before you leave. In addition to recordings of today's seminar being posted on our YouTube channel, a number of related handouts are available on pwdf.org. Today's session is divided into 4 sections. They include Dr. Tammy Duong of the University of California, San Francisco, Department of Psychiatry and Behavioral Services, who will start the day off with a session titled Aging Minds Matter. Mental Health Considerations in Older Adults. Avonelle Hanley-Mills and Abounds from SOLVE, Sharing Our Lives, Voices and Experiences, where we will hear about first-hand experiences navigating mental health changes when over the age of 65. Janet Espy of Espy Law Offices and PWDF board member will then discuss mental health considerations when navigating end-of-life planning. And finally, Abel Mouton from Legal Assistance to the Elderly and Kristen Acevedo from Tenderloin Housing Clinic will discuss housing options and landlord-tenant rights and responsibilities. Our moderator today is Jesse Wustoff, PWDF's Program Manager for Public Awareness and Education. A few last reminders: emergency exits are down this hallway to the right. You'll see the staircase there, and the same protocol for individuals in wheelchairs will be in that same station. They've informed me that they have a holding area for wheelchair individuals, and they have an evac chair in that corner. Please make sure, lastly, that your cell phone ringers are turned off. And now our first speaker, Dr. Tammy Duong, is a director of the UCSF Geriatric Psychiatry Fellowship, Associate Clinical Professor, Vice Chair of Medical Education, and the Ambulatory Executive Medical Director and Adult Behavioral Health. Her clinical practice focuses on older adults with psychiatric manifestations of neurodegenerative disease, delirium, and late life mood and anxiety disorders. She completed her adult psychiatry residency at the University of Southern California and Geriatric Psychiatry Fellowship at UCSF. Her interests include geriatric psychiatry, neurodegenerative disorders, ethics, medical, education, diversity, equity, and inclusion. We are grateful to have her join us. Dr. Tammy Duong.
Thank you so much, Alan. I'm going to stand to the side of the podium because I'm a shorty cakes and you can't see me if I stand at the podium. So I have a lot of slides, and I've been told I'm a chatty Cathy, so I will do my best to keep us on time today. So this talk is called Aging Minds Matter, and I think I'm supposed to remind everyone that these are my own opinions. I'm here kind of on my own, not necessarily representing the University of California. So today, and I have no disclosures, nobody pays me enough money for that. So really today, I hope to talk to everyone a little bit about kind of what do mental health presentations look like in older adults. That could go on and on and on and on for many days. It would take you a whole year to learn everything. That's why we have fellowships. And then I'll talk a little bit about what are some of the barriers that I see that our older adults face in actually accessing mental health care. And then we'll talk a little bit, I like to try to leave us all with a little bit of hope for the future and talk about, okay, let's talk about what we can do. What's the next steps here? So I'll start us off with a quote. And I get this like referral message almost every single day of my life. And you notice I had a lot of titles. And so this question comes up all the time. I've got a patient with a pressing need, urgent, and we need a geriatric psychiatrist. And I need someone to see very soon. Can you please help? And here I am at UCSF, this wonderful medical school, and how many geriatric psychiatrists do we have on faculty? I can count them on one hand, right? I mean, there's about 4 of us. One is more or less retired, and he throws me a bone and he hangs out, which leaves 3 or 4 left of us. So there's just not enough people to do all the needs that we have. So let's talk about part 1, the need for geriatric psychiatry. So we have the saying, why is there a tsunami here? We have the saying in geriatric psychiatry that get ready for the silver tsunami, or 0 hour is another thing that it's called. And what this is that's when the baby boomers turn 65, right? Our most populous generation, when they go into older adulthood, and we're going to have a lot more older adults, a lot more people to serve. We heard some statistics earlier. I've got some more here. These might be a couple years out of date and maybe more than this. But, by 2030, just what is now 2025, in 5 years, we'll have more than 73.5 million older adults in the United States. We'll have 83.7 million by the year 2050. This is a lot of people. There's more patients than I can see myself, right? Than the 4 people on my faculty than can see. And another thing is I wanted to point out is that in this population, among all these people, we're going to have a lot more women, a lot more kind of underrepresented people in this age group. So we also not only just need more geriatric psychiatrists, we need to diversify too and actually serve and match the people that we're trying to serve, right? So I've got some statistics here. And so you can kind of see these minoritized populations, they're growing, right? We're not getting smaller, we're growing. So we've got this increasing demand. And we know out of all those people, who's going to need mental health care? So we know about 20%, about a fifth of that population of older adults is going to need some kind of mental health need, right? And what are the things that we're going to be looking at? We're going to be looking at comorbid neurodegenerative disorders. We're going to be seeing people who are just doesn't have dementia, but have some kind of cognitive impairment. People who are just generally kind of more frail as they age. These are the people who need help the most, right? Minoritized aging adults, right? They're more vulnerable, and they're more vulnerable for a lot of reasons, right? There's a lot of minoritized stress there. It's a lot more difficult to actually access services and needs, and having them kind of help navigate through the healthcare system, right? And just kind of like the system at large for all these other services we're going to hear about today, right? And I keep emphasizing this point because everyone reaches out to me. If we're going by the way we're going, the ratio of geriatric psychiatrists to patients is going to go from 1 to every 23,000. I can't imagine having 23,000 patients on my panel, let alone this is going to go to 1 geriatric psychiatrist for every 27,000. And I could work every day, 14 hours a day, and never meet this demand. Right? So, so what this leaves us with? This leaves us with the unmet needs of older adults, right? And what does that get us in return? Not meeting the needs. Well, we know that we're just going to have, in general, less well-being, right? There's more loneliness and social isolation. And so you're going to hear me talk throughout this talk the themes of loneliness and social isolation. And when I say loneliness and social isolation, they're actually two slightly different definitions. So social isolation is not having kind of people around you, right? And then loneliness is maybe you have the people around us, but you don't quite connect. So you can kind of see how they're overlapping. They're not exactly the same thing. But we do know those two factors go into a lot of other things, right? So if you are suffering from loneliness and social isolation, we know you have worse quality of life. These people tend to have just kind of worse health status overall, right, which leads to greater disability, increased morbidity, mortality. And once you have all of those things, that puts a higher cost on society as a whole, right? That we just need more and more resources. And we have to be able to take care of everyone, right? So all of these things are just interconnected along the way, right? So I have painted such a sad picture for everyone. I'm so sorry. But so that's kind of the need. And then when it comes into my office, what does this look like when this comes to me, right? So this is just kind of the tip of the iceberg. So we'll talk a little bit about common geriatric syndromes. And this is, again, just real fast, I'm going to run through these things. This is just high overview of things. I could go, like I said, 10 hours into each one of these topics. So we'll open it up for questions later. But the most common things that I see, one of them is depression. And so when I talk about geriatric depression, depression's just, it's not common. It's not only common to older adults. It's common to, right, everyone and all adults. And so when I say geriatric depression, I think of two broad groups. They're the people who had depression when they're younger, and now they've aged into older adulthood, right? You're older, now you have depression. And then there's the other group, which is new onset depression. They've never had depression in their lives, and something has happened to them. There's a big life stressor, something's happened, and now they have depression. And why this matters, I tell my fellows all the time, is because, the prognosis is a little bit different. The treatment might be the kind of the same, but one tends to do a little bit better than the other group of it. And so it's important to keep that in mind, right? And because it helps direct our treatment. Depression is very costly, right? If you think about depression and what it does to us and some of the symptoms. I mean, we just don't feel well. We can't get up. We're just laying around all day, right? So we get more deconditioned. We get more frail. So this actually costs us like billions. Yeah, I had to double check that number of that's billion with a B, $43 billion annually. That's a huge chunk of money, right? And not all the seniors who have depression are coming to see me. And actually, a lot of these patients are being treated by their primary care providers. One of the things that I do is I am integrated into a primary care practice to try to help them out a little bit and try to take some of that pressure off of them. But I will say geriatrician medicine doctors are wonderful. I can't sing their praises enough because they're really good with treating geriatric depression and all the complex comorbidities that go along with it. And they're usually they're not afraid of older adults with depression. So I thank them a lot because I couldn't do this job without them. But if you don't have a geriatric psychiatrist in your office, and it's not common to have a geriatric psychiatrist in your primary care office, what commonly happens is that these patients get undertreated or not treated or misdiagnosed in the reality of it, because a third of these patients are going to be treated with sleeping medications, not antidepressants, right? And then maybe a third of them are being treated with antidepressants, but they know how to start a medication, but they don't know how to titrate it. They don't know to get to a therapeutic dose. They also may not know, what do I do if I use one medication and it doesn't work, right? These things can get complicated fairly fast, and we're not always doing our best job of, equipping our colleagues in primary care to treat the need as well. All right, so what does it look like, right? I've said this is, and I may go to the top of the slide and then kind of go to the next slide. I realize I repeated some things, but who's most at risk for depression when you're older, right? So what we often see is you've got maybe someone who was doing just fine in life, but all of a sudden they're facing multiple losses. One really common thing that I hear is, well, everyone around me is dying. I've got no one else left. My oldest patient, she was 105, recently passed away, and she would say to me all the time, kind of this passive thoughts of death, like, yeah, I'm ready to die. It's fine if I die. And why is that? Well, I've done everything, and I have literally outlived everyone else. And you know, you kind of have to go like, yeah, it's common, but also not okay. That's the other thing that happens with older adults. They go, well, aren't I supposed to be depressed? And I say to them, yes, it's common, but it's still not okay. We should still do our best to help you out, right? Then you come with the older adult who, you know, was really active in their younger days, really independent, and, you know, they're having some kind of loss in their health, bodily function. They're just not mobile, agile, or able to do what they used to be able to do when they were younger. And that's really hard too. If you're really independent, all of a sudden you can't do the things that you're used to doing. That's hard, right? So that's a vulnerable group of people, right? And then cognitive decline, which is really tough because for some older adults, there's that period of time where you know you're fine and you kind of know something is going on and you know something isn't right, and that's really, really scary, right? Not everyone has that insight, but some people do. Right? And they get a lot of anxiety, depression as a result of it. And then there are a ton of other setbacks. Like I said, social isolation is coming up again, loneliness, right? Financial is a big thing. So I also have some patients who come to me and say, you know, doc, I wasn't planning on living this long. Now I'm worried about these finances. And because I hadn't actually planned on living this long, what am I going to do? I actually had someone who said, my gosh, I'm really worried about Social Security because that's my income. What am I going to do, right? So these are real worries that come up. I'll skip this bottom part because it bleeds into the next part. Is that, you know, so this statistic is a little misleading, and I use it to trick my fellows when I'm teaching with them because, you know, 4% of community-dwelling older adults have, you know, major depression, and that doesn't sound like a lot, but if you think about it, who are those community-dwelling older adults? Sometimes it's the people who are really healthy, doing well, independent, right? So it's a little bit of a skewed statistic. And if you kind of jump down to that bottom bullet point, if you look at geriatric psychiatry units, the majority of patients who are being admitted actually have major depression. So it kind of depends where you go. If you go to an inpatient unit, you go to an inpatient hospital unit, a lot of those patients have depression. If you go to a skilled nursing home, almost 50% of those patients have depression. So it's all about the population that you survey too, right? Statistics can be misleading. But we also know depression is just very common lifetime. So 20% lifetime prevalence of major depression throughout the whole population. So that means 1, 2, 3, 4, 5, right? And 1 out of every 5 people would have a diagnosis of major depression. So it's very common, right? So this statistic too is common as well in younger adults and older adults, that the ratio of women to men. So women, it's a ratio of about 2 to 3 to 1. So women are more likely to develop depression than men, right? And I've already talked about these last couple statistics that, you know, if you're in a nursing home, you're ill, all of those things, higher risk of depression. So what does it look like? What does it actually look like for an older adult, and how can you start to spot it? The ask isn't for everyone to be able to diagnose depression here. That's an outrageous ask of me, but like generally know kind of what it starts to look like, right? And as you'll notice, as I go through this talk, depression can look like other things too, right? So common symptoms in older adults. A lot of times the first thing people come in to say, they'll talk to your primary care doc, is they're having problems with sleep, which is it doesn't mean you have depression, but it's really common for older adults to have problems in sleep. You might hear things like, you know, they're just not hungry as much anymore, you know, they've got a lot of aches and pains. But you know what? A lot of medical illnesses have these same symptoms, right? And so it's like when you have a hammer, all you see is nails. I think that's a thing I hear all the time. So my residents who are psychiatrists and my fellows who are geriatric psychiatrists, I try to warn them all the time. You know, you've got those symptoms, but could it be something else too? You always have to, when you're a geriatric psychiatrist, I like to think of myself as you're part family doctor, you're part rheumatologist, you're part psychiatrist. You got to be aware of all the things that are happening, right? And then the other symptoms that tell me like, aha, maybe there's a little bit more depression, is you might hear other things, right? Not enjoying life or activities as much, not as excited to do things as much. And you may hear a lot of synonyms for depression, because older adults may not say the word depression. They may not say that they are depressed. They may say they are sad, they are blue, they are feeling down, they're just not with it, they're just not themselves. So I've got to be really attuned to ask the same question in 4 different ways, 5 different ways sometimes, to get the information. Because I think the older adults who are coming through now have a little bit more of a vocabulary for it than a generation ago when I used to see that population. So it's starting to change. Awareness is starting to change, but still, it still hasn't been as talked about, 40 years ago as it is now, right? And then some people may have other kind of more severe symptoms, like feeling hopeless, guilty, thinking about death. I mean, I have older adults too who just commonly say, yeah, I'm thinking about death. And, and in some degree it is normal when you're older to be thinking about death, because it is, mortality, and you need to prepare, right? But there is a line that gets crossed when I'm thinking about death and versus I want to die. I'm going to do something to hurt myself, right? There's a really fine distinction there that I teach my trainees all the time to try to pick up on that distinction. And in some cases, and this often gets missed in older adults, that in really severe episodes of depression, people can get really psychotic. And that can be kind of subtle sometimes. So what I call psychotic guilt. It's this thought that, nobody cares about me, nobody loves me, I'm going to be in financial ruin. Or it could be, I had a patient one time, she was convinced that she had cancer. Tall woman, thin, and you kind of go, well, do you have cancer? Maybe you do. $1 million workup, it's no cancer, but she couldn't be convinced. And then I remember trying to start a medication with her, and that nice little question, which medication do you want, this one or that one, just kind of pushed her over the edge. And there's no convinced that, like, if I'm here, I'm going to be in financial ruin. And I talked to the husband, and he's like, we have lots of money, we have insurance, this is not true at all. And I realized, oh, you're really psychotic right now. Oh, okay. And sometimes people think it's anxiety, and because they're really, really worried about something. Like this woman was really, really worried about cancer, even though she couldn't be convinced otherwise. And there's that really fine line, and that fine distinction sometimes where it just didn't make sense, right? And like I mentioned before, so what you might see less common in older adults, you actually might see, so when you're younger, we tend to see a lot more like low self-esteem and guilt. I know I just went on this rambling rampage on psychotic guilt, but kind of just guilt in general is a little bit less than older adults, because the great thing I really enjoy about older adults is they've learned throughout time to kind of build up that sense of self-esteem, and some resilience. And so I always find that like that's really lovely. So we see less of that. But what I see more of, and I mentioned this before, is a lot more of those physical complaints. Those just seem to get amplified. I mean, if you think about it, if you already had those symptoms and now you are depressed, those symptoms just get worse, right? So headaches, fatigue, dizziness, cognitive complaints, all of those things can get worse with depression. And sometimes that's just what people come in to say is what's wrong with them in the first place when they see the doctor. And then in some cases, what I see is kind of things like, and this is things like food refusal. So this is in my very frail patients. Sometimes they're very sick as well. Sometimes they have some cognitive impairment where they just get so passive. They just kind of passively, slowly decline, and it's almost kind of like a failure to thrive, where they're just not eating, they're just neglecting their hygiene. One of my favorite patients, like favorite patients, I remember whenever she would get depressed, she would stop cooking, and she would just kind of do like heated meals, in the microwave, canned food, just like really easy food. And I remember the first time I met her, I went, does she have dementia? Like, she seems a little cognitively impaired. And we treated her, she got better, and like, whoop, that cognition just bounced right back, right? And then she got depressed again some other time, and then again it looked like she got a little cognitively impaired. And so when we see those symptoms, we call it pseudo dementia, which I'll talk a little bit about later. So there's a risk factor if you have kind of depression is a risk factor for cognitive impairment and depression, and then cognitive impairment and depression is also a risk factor for depression. So we know there's this bi-directional relationship here. So we do worry about depression for a lot of reasons, for your health, but also kind of to keep your brain healthy, right? So I've talked about the risk factors for depression, but when you have depression, what is this a risk factor for? You know, I already talked about kind of the Alzheimer's disease, dementia, kind of the dementing illness. But as we know, it's a risk factor for completed suicide as well. We know older adults, when they do attempt suicide, they sometimes pick the most lethal means, right? Like really violent means. And so they actually have a greater, I don't remember the statistics, so don't ask me the statistic later, but it's a greater risk of completed suicides versus when you're younger and, you know, and maybe you survive. So it's a lot more lethal for older adults, right? It also, we know that for depression, there's this kind of bi-directionality for other diseases like cardiovascular disease, right? And so I think depression, I had in some other slide deck, I think it's like cardiovascular disease has like one of the highest morbidity mortalities in older adults, and depression is like number 4, I think. So, you know, it's just a risk factor in general for disability. What are some of those poor prognostic factors for an older adult with depression? So I mentioned chronicity, and that's the difference, right, with someone who maybe had depression and now they are older and they've had depression for a longer time versus someone who's now older and they're now developing depression, right? And so the longer you've had it, the worse your prognosis is. So a lot of times there is some urgency in treating depression for that first time, right? If you have other comorbid illnesses, other things going on, poor social supports, functional limitations, all of those are poor prognosticators. All right. I'm gonna speed myself up here because I realize I got like 15 minutes. I got a lot of talk to go. So I'll keep going. Let's talk about anxiety for a second, right? One of my patients told me one time, she's in my office, she's like, "Doctor, aging is not for wimps." And I was like, that is correct, isn't it? And so anxiety is kind of, it gets better and worse when you're older. In terms of, you know, younger people, you know, the most common anxiety disorders are things like phobias, like specific phobias like fear of flying, fear of spiders, right, and panic attacks. Where that's not as common, I mean, some of that's common in older adults, but what you get is like more of this kind of unspecified anxiety. So it doesn't fit neatly into the diagnostic categories, but we do have a lot of worry for older adults, right? And you know what happens when people worry? They start to avoid things that are worrying them, right? So if you think about an older adult, if now they're worried about like falls and going out into the world, well, their world just started to shrink a little bit, right? And a little bit more and a little bit more, a little bit more, because now they're just avoiding lots of things, which is not great. It's a risk factor for, you know, more anxiety, depression, things like that. And so, you know, when we think about worry, I mean, there are some adaptive things to worry, right? If you think about it, there's, you know, this curve of like, you need a little bit of worry to get things done, but too much and you just kind of crumble, right? And so we think of worry as kind of the short-term response to something kind of uncertain. It kind of is a call to action. It like fuels this belief that, hey, we can control what's going to happen. But you worry too much. And, you know, one of my supervisors used to say, well, don't waste a perfectly good worry. And I was like, yeah, that's about right. And what she meant with that is some things, you know, you worry about things, but some things actually aren't in your control. And so sometimes worry is a choice. You can actually decide what you worry about, right? And that's a little bit of the treatment of retraining yourself. But for older adults, the common things that I hear that they worry about is finances, their health, their family's health, right? One of my patients this week she sat in my office and she was just so worried about her son who was having surgery, not her own health. She was doing great. For once, I'm going to knock on wood because I don't want anything bad to happen to her, right? But we just sat here kind of talked about her family and how she's worried about her family the whole time, right? So anxiety disorders, whoops, Yeah, here we go. So what's less common in older adults is kind of like I said, those phobias, those panics, and those kind of what we call like generalized anxiety. But what becomes more common is kind of that non-specific anxiety that doesn't fit into a neat diagnostic category. Um, and anxiety symptoms are common. 20% of older adults experience anxiety and worry at some point, right? Which is a lot, which again, it's 1 in 5. And I mentioned this before how anxiety can be a little bit protective, but also too when you're older, that can be a little bit protective for anxiety. Because what I really like about older adults is that they've seen stuff before, right? Like they know how to handle themselves. They've learned this is what works for me. These are the tools I've got, and so I'm going to use those, right? And they already have this great set of coping strategies. I love that. It makes my life easier, right? I'm like, ooh, less work for me. Let's just like build on those skills, right? So I actually have a lot of fun with this age group. But so I'll just kind of quickly go through, what does this look like for some of these common disorders? And so for this generalized anxiety disorder category, what you'll hear from people say is they worry about everything. Like you ask them, what are you worried about? And they're just listing off everything, finances, being awake, what are you going to wear, what are you going to eat, right? I mean, and it's just like, it's hard for them to stop. And I'll ask them, can you focus your attention on something else? I'm like, nope, so worried. Can't do anything about it. And this worry bleeds into, and this is very common, that their mind is just going all the time. They can't fall asleep. So you'll commonly hear about like, I'm having trouble sleeping. Sometimes you hear, well, like if they're so keyed up, they get really irritable and snappish, right? They're just snapping at everyone, and maybe they weren't all that snappish before, and they're just kind of feeling on edge. And what often happens is why they're seeing their primary care doctor is because they're so tense, right? There's like I had a patient, I'm like, your shoulders are up here, my dear. Lower these shoulders down. They have so much muscle tension, right? Which can cause like headaches and jaw pain and fatigue and stomach aches. So you can get all these hosts of physical symptoms too. And sometimes they don't even know that they have anxiety. You kind of almost have to go through the whole thing and go, could it be that you're also worried? And then, you kind of get this look like, yes, yes, I am very worried. So people don't even realize it sometimes. Whereas panic attacks, patients definitely know when they're having a panic attack. And these are the people I get that phone call into my office of like, I am having like sweats and chest tightness, and I think I'm having a heart attack. And a lot of these patients will go to the ER with these symptoms, and it's no heart attack. EKG is fine, right? And what this turns into just this like worry that they're going to have more panic attacks, and they just feel like they're losing control. And sometimes they just kind of feel like they're just not in their bodies anymore. Like they're just kind of not with it. And for the typical panic attack, it'll happen quickly, and then it'll last for a while, and it'll go down. And what we think is happening is what you can't really see in that kind of circle is that a lot of times that panic attacks they start with some kind of internal, some kind of physiological change, and then the worry happens, right? And then it's like a feedback loop, and then it triggers more symptoms, right? And which causes fear because it's uncomfortable. And so you're almost kind of stuck in this loop. And so what ends up happening is people think that they need to go find the trigger. Something triggered this panic attack, this anxiety. And sometimes the tricky thing is, sometimes panic attacks are triggered, but sometimes they're not triggered. Sometimes it's something internally, physiologically that's happening. And what happens is they misattribute some kind of external stimuli to that panic attack trigger. And so they'll go, well, sitting here in this room with all these people caused that panic attack, so I'm going to avoid all people, right? So then that kind of goes into avoidance. And again, their world gets smaller and smaller and smaller. All right. So, common medical conditions of what anxiety looks like. I mean, it could look like a heart attack, right? That's really common. It could look like an arrhythmia. It could look like someone's hyperthyroid. And so, what I'm doing as a doctor is I'm also going through all these things to make sure people don't have the things on this list, right? And so, again, it's like when you have a hammer, all you see is nails. And I'm trying to tell my psychiatry residents, you got more than just a hammer. Use all the tools in the toolbox, right? We don't want to miss some of these other things that are really serious, like a pulmonary embolism is very serious. We don't want to miss that, which is why I think maybe if I have time, I'll go into this later. Why sometimes it's challenging um, to be a geriatric psychiatrist, because you got to know a lot of medicine too, and I think people get a little bit scared off from that. Okay, I'm gonna keep going. Let's talk about the brain, right? And let's talk about cognition. And you need to know about the brain, and I won't dwell on this slide too much because it can get kind of complicated, is that, your brain has all these different parts of it and helps you do a lot of different things, right? It helps you make decisions. Your brain helps you remember things. It helps you actually, solve problems and keep your manners in check. It helps you talk. It helps you actually know where you are physically, and it also kind of helps you, relate to other people. And if any of these areas get damaged, right, then we have deficits. And so so the broad term is cognitive impairment. And dementia, what happens is you have one or more impairments in one of these things, right? And this is a change from baseline too. And so, for example, people with autism might have a deficit in one of these things, but that's their baseline, right? And then if they got sort of a fall in another one of these things, then we might start to worry, like, okay, is there also like a neurocognitive or a dementia process happening here, right? And so, what's normal and what's not normal? Because some changes we see are very common and are normal as we age. So, what stays the same? Well, so like a lot of times your social skills stays the same, your vocabulary, the experience that you bring with you stays the same, right? Your intelligence stays the same. But what starts to decline and what's normal is processing speed. So sometimes it just takes people a little bit longer to pull out that information. People tell me all the time, like I remember that name of the thing, but it just took me extra time. And I go, okay, that's great, that's normal. One of my geriatric psychiatrists here, wonderful guy, one of the godfathers of geriatric psychiatry, we're sitting in conference, and I tell all the new trainees, like, he's gonna say something brilliant. It's gonna be uncomfortable because he's gonna pause, and you're going to want to say something. I'm like, don't say anything. He's going to say something brilliant, right? It just takes him a little longer to get it out. And he always says something like incredible. So you just kind of have to know that with older adults and just enjoy it, right? But like I said, attention might be less efficient, right? Things like that. Those things are normal. But why is that happening? Well, a lot of things are changing. Receptor density is a little bit less. We won't go into it. But those things are normal, right? But what we start to worry is that sometimes we get into these kind of three broad categories. Is this subjective cognitive impairment? So I hear this from a lot of my older adults who are just fine. They're like, I feel like my brain isn't going as well as it has in the past, right? And you do testing, you do everything, they're fine. They're doing just fine. So we call it subjective cognitive impairment. And sometimes, I mean, that's true because they just don't feel like they did when they were 40. And I try to tell these patients all the time is you're not being fair to yourself. Why do you expect to function the same way 40 years ago, right? So go easy on yourself a little bit. Mild cognitive impairment is when you have a deficit in one of those domains, but you can still take care of yourself. You can still get your day-to-day functioning just fine. And then what goes into dementia, what used to be called dementia, now it's called major neurocognitive disorder. They're the same thing. We just like fancy words. Is when you actually have impairments in some of those domains and your functioning starts to slip, right? That's when we start to worry. And so this is very common, unfortunately. And so your risk of converting into dementia doubles every 5 years after the age of 65, which is kind of a scary thing, right? Individuals over the age of 80, about 40% have some kind of like cognitive deficit to it. And this is projected to grow, right? And this is very, very costly in the healthcare industry. So I could spend days talking about dementia and all the different subtypes. And actually, there's a lot more subtypes than these four. These are the big ones. It gets really, really into the weeds, and some of these actually have some subtypes to them. We won't talk about them, but so dementia is the umbrella, And Alzheimer's, vascular disease, Lewy body, and frontotemporal dementia, those are subtypes of dementia or major neurocognitive disorder. And if you are a betting person, I'll answer your question. I'll just finish it. Go back one. Sure thing. Okay. Okay. If you're a betting person and you had a guess, it's usually Alzheimer's, right? That's the most common thing. It's super duper prevalent. And so I tell my fellows, like, we play this game all the time. We're like, is it dementia or is it not dementia? And if it's dementia, what type of it is? And what happens is at the beginning of it, like, you can tell the differences between the dementias, but the longer it goes, it's harder to tell the differences. They start to look very similar, so it can get very confusing. And so I'll just say a few words about Alzheimer's disease because it's the most common. And what the signature of Alzheimer's disease is, it's memory problems, right? And so what we normally see is like short-term memory is affected because if you go in your brain right here, right by your temple, you go straight in about like an inch or so, you'll hit your hippocampus. And the hippocampus is where we form memory. Oh, 10 minutes. All right. This is a lot more than I thought I had. I'm going to get through this. Excellent. Thank you for that. And so if you get the hippocampus, that is exquisitely sensitive to damage and stress and oxidative stress. So a lot of times what we see is memory starts to go first. And so what people might start to say is they just kind of forget that things happen. It's like you have the same conversation multiple times and you find yourself repeating yourself for that person. Maybe they start to misplace objects around, or they're getting lost, they're forgetting their medications, or they're getting lost in their neighborhood. Like a place where they've lived for the past 40 years and they have no business getting lost to, right? And all of a sudden they just kind of forget their way and don't really know where they are. But what stays intact is I hear all the time, oh, but dad can remember what we did as kids, right? And to me, that makes sense because those memories, those kind of long-term memories, they've already been consolidated. They've already gone through the hippocampus, through the whole thing, and they get stored other places in the brain. It's just forming new memories, which is the problem, right? And I'll talk a little bit about, so what I see as, unfortunately, we still don't have any great treatments for Alzheimer's disease. But what I tend to see is the neuropsychiatric symptoms that go along with dementia or Alzheimer's disease, right? And 80, I think I had some other slide deck. I mean, it is like somewhere between 60 to 90% of patients with dementia at some point have some kind of behavioral issue along with them. And so some of these things I'll show you on the next slide, it can be very non-specific, right? But it's a problem because who's it a problem for? It's a problem for the patient because they may be engaging in like not safe behaviors, bigger risk of falling, getting lost. But it's a big thing for the caregivers too. Oh, yeah, you had a question. Mm-hmm. Yep. Mm-hmm. Yeah. 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 Yeah, that's a yeah. Yeah, that's a great question. I get asked that question every day. And so it depends a little bit of kind of what phase they're in. So the people who are subjective cognitive impairment, mild cognitive impairment, this or even early dementia. This is what I say to them. It's all about protecting your brain from further decline. Because the terrible thing about these disorders, they're neurodegenerative. By definition, they get worse. But we can try to slow it down and optimize the other parts of their brain. And so how do we do that, right? And I tell people like, okay, so that you use your brain for lots of other things. Physical activity, right? Keeping yourself cardiovascularly healthy as possible. Because we know that vascular disease, the disease you have in your heart, can also happen in your brain, right? So we try to keep people physically healthy. We try to keep people socially healthy because we know, again, social isolation, loneliness are also risk factors, right? For not just for depression, but for cognitive disease as well. Um, Treating anxiety, depression, the psychiatric symptoms. I pointed out bi-directional relationships. So we want to actually treat those comorbidities that might accelerate the disease. And then finally, it's just keeping your brain active, right? It's kind of how do you be engaged in something that is engaging and meaningful to you on a daily basis, right? Those really, the evidence is we've got those have the best evidence. It's not actually anything fancy or medication wise. It almost kind of seems too easy and like the things we should be doing anyways, but that's actually the best evidence that we've got. Yeah. 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 Absolutely. Yeah, absolutely. Yeah. So I've got 1 minute left, I've realized.
Can you just
And
repeat what the question was real quick?
the question was is how do we treat cognitive disorders really? Well, like what's the best treatment? What's the evidence we have for them? And the answer basically is we don't have any great medications. And it's just those things that I mentioned, right? Staying healthy, being active physically, mentally, treating all the comorbid, both physical and mental disorders. Seems simple. Yeah. Well, how about this? This is my last 30 seconds. I'm going to skip all the way to the end I had a lot left. Like I said, I'm a talker. To what can you do here? Moving the field. How do we move the ball, right? Because geriatric psychiatry, I'm sad to say, the section that I skipped, it's a little bit of a dying breed. Sometimes I am out there recruiting on my own, trying to convince people to go into geriatric psychiatry. So it can't just be me. This has got to be a team sport. And so some of the things that we're doing is trying to integrate into other care settings, go to where the patient is, right? Try to focus more on community-based interventions, really trying to do preventative care. Telehealth has really changed the game. And now I can treat people. It used to be I could only treat people in San Francisco because they had to be kind of well enough, physically well enough to come into the clinic, or they had to be in San Francisco where they could come in. Now I treat people, in Sonoma and places far away, right? And finally, we've got to expand our workforce because I can't do it myself. So we've got to train other people to how to spot it. And I'm part of the American Association for Geriatric Psychiatrists. This summer, they're launching a certificate program of like working with older adults. So we've got to just share the information. And so what you can do, just talk about it. Share this talk with anyone. If you know someone older, we know this intergenerational connectedness means a lot, right? Preventing social isolation, loneliness. That's kind of the underlying theme here. That really helps. So just being out there, looking out for each other, that's going to make a big difference, right? Okay, so I will end there, and I will give it back to yeah.
We're going to go ahead and have a Q&A. We're going to have a Q&A if all the speakers could go ahead and come on up. Feel free to ask anybody any questions right now. We'll focus mostly on Dr. Duong's presentation, but sometimes questions have answers that can be supplemented by other speakers. So Joy, you can go ahead and come on up here as well, next to Avonelle. Yeah, go ahead. You're fine.
And for the folks on the stream, we're going to ask you to use the microphone, please. So if you have a question, go ahead, raise your hand. I'll run the mic over to you.
Thank you so much. All right, so a lot of information to cover. There are a lot of topics that we would love to hear more about, but we're going to go ahead and narrow down to a couple. I want to go ahead and start off. Are there any audience questions? Okay, we have one in the back there.
Are there natural dietary things that older adults can take to maintain their ability to recall short-term memory, like specifically either vitamins or herbs or food that we can feed them?
Question. Oop, there we go. I assume that question's coming to me. Okay. Yeah, it's a great question. And you know what I tell older adults? I mean, the best thing that you can do is maintain your health. So those same vitamins that you are going to take otherwise, we know a lot of those things are cofactors, right? For catecholamines, for neurotransmitters, for example, like older adults are told all the time to take vitamin D. You know what? That's actually a cofactor for serotonin synthesis as well, right? We know things like having enough B12 and thiamine in your diet are also neuroprotective. You need those things for lipid production, which is in your brain, right? So these are the same vitamins you'd be taking otherwise, right? Making sure that you are not anemic and you have enough like iron in your diet, things like that. So it's not anything groundbreaking. I mean, it almost seems like common sense, but these are real things, and the real things that your primary care doctor tells you to do, do them because they help.
I mean, I feel much better about the vitamins I'm taking. I like that answer. All right, we'll go ahead and give the mic back to the audience in just a second. I'm going to insert one question related to, oh, did you have a follow-up? Hold it. Speak into the mic, Kristen. And that's Kristen from Tenderloin Housing Clinic. You'll hear from her more later.
I just wanted to piggyback on that because another thing that you can do is puzzles, board games, word searches are really helpful. I don't know if you do crossword puzzles, but puzzles and board games are really engaging. Not only do they maintain your cognitive function and they're healthy for you, but it's better for your memory. It's better also like the hand-eye coordination. A lot of people I have a senior building with Tenderloin Housing Clinic, and one thing that we do is bingo. And people don't understand that bingo, that's hand-eye coordination. That is paying attention to the people in front of you and the presenter and what they're saying. It's listening, it's looking, it's the hand-eye coordination. All of those things you got to maintain those as you age, not just that's for everybody, but especially for our seniors, it's super important. Like games are really underrated, and reading, audiobooking, radio, those are all things that can keep you engaged and keep you healthy longer.
Shout out for solitaire in the
100%.
audience.
100%. I learned how to play also Texas Hold'em with my clients. I didn't know they taught me, but it's awesome. That decision making, that paying attention, your interpersonal skills, and really paying attention to the table. All of those things are super helpful.
Thank you. So Dr. Duong, I wanted to talk a little bit more about misdiagnoses. I remember when I first was starting my disability studies, graduate work, I was worried about underdiagnosis, and then misdiagnosis actually became the beast that we really need to talk about more. When it comes to UTIs, things like blood sugar spiking, it can actually, people think it's dementia. They think they're having an episode related to dementia, but that's actually not the case. I'd love for you to talk about those common misdiagnoses, and maybe what tests you can insist on if your loved one has these sudden changes that did not increase gradually. What tests might we want to look at?
I love that question because once again, I'm always telling my residents, use all the tools in your toolbox, because I think in geriatric psychiatry, and what you said was perfect, if there's a sudden change, because the difference between, I think, dementia and delirium, which I didn't mention, or some of these other disorders, is that time course. If something is kind of slow and progressive, all right, it's a little bit different if it's a sudden change. If it's a sudden change, I'm usually thinking, oh, something else happened. You mentioned UTI. That's like the first thing I start asking about. I ask a lot of people, surprisingly, as a psychiatrist, about their like urine and then bladder function and their bowel function, because it's actually really salient. So, I mean, every year I get this new group of residents, and they're like, oh my gosh, this patient, something's wrong. I'm like, did you check for a UTI? Can we order some urine? And then they go, oh, that's what it was. You look like a genius. I'm like, it wasn't that hard, but we should always be thinking about these things, right? And so there's actually, when you start, there's a workup that we do. It's usually you get urine, we're looking for UTIs, we're getting thyroid function, because if your thyroid, if it's too low or too high, can cause anxiety, can cause you just not to think very well. any kind of infection, like if you had a skin infection or pneumonia, people can get confused, right? They can get delirious. And then I kind of mentioned those vitamins too. Sometimes if you're really anemic, you're just kind of not thinking straight either. And you mentioned blood sugar. We had a patient who got referred to geriatric psychiatry, had these like uncontrolled sugars. They gave him a diagnosis of frontal temporal dementia, which is a very serious diagnosis. And then his blood sugars got under control and he was himself again. And I went, congratulations, this never happens. You've never had dementia, right? So there are a lot of things, but I think as geriatric psychiatrists, and again, I think this is why people get a little scared from geriatric psychiatry. You have to be thinking about these things. And then you also have to be thinking about the drug-drug interactions that happen too.
Yeah.
Because sometimes older adults get put on a lot of medications and they don't always play nicely and they have interactions and people don't realize it. And something else happens and they may look, delirious or not cognitively with it either. So there are a ton of things.
I love you mentioning the drug interactions. I've seen that as well. And I always recommend, if your doctors aren't on some sort of computer system where they can see everything, you bring that printout with the dosage and the frequency, because it's apparently very easy, as I've observed, for there to be drug interactions that the GP would not have been able to flag otherwise.
Yeah.
So I love that.
My favorite families, they bring me that whole list.
Yep.
And it's all like color coded. And I go, ooh, thank you. Can I copy this, put this in the chart? So it's very easy to lose track of medications. I think, and sometimes the primary care physicians send me patients just to review the medications that they're on. And they'll say, Dr. Duong will look at your medications and tell us if there's any drug-drug interactions.
Yep.
Right?
I literally carry family members their list on my phone.
Yeah.
Because you never know when you're going to need them.
Thank you for
So I
that.
love it. Yep.
I really value that.
I'm ready for an emergency. All right. Take one from the crowd.
I have a friend who is in her mid to late 70s, and she believes marijuana is medicine because she was diagnosed by her psychiatrist with anxiety and depression, and she said that marijuana helps her relax. Do you think marijuana is good for a woman? She's a Caucasian woman, around 70, between 75 and 77.
Yeah, that's a great question. I think the topic of marijuana and cannabis has gotten really popular in the last 10 years. I mean, since I became a geriatric psychiatrist, maybe a little bit before, when I was practicing just general psychiatry. And, I think that's a function of this generation's a lot more comfortable with marijuana and cannabis than prior older adults. So the question comes up a lot more, and I almost got really surprised. And so I'll give you my stock answer. I don't know your friend, so I can't say specifically what's right in her case. Everyone is individual. So I'll tell you about the studies are still not there. We still don't know enough about marijuana and cannabis to say one way or another. So I usually say to patients, I'll tell you what I know. You'll have to make this decision on your own. And I can't endorse any particular thing. So what we do know is that cannabis affects what we call these sort of nicotinic receptors that are involved in learning and memory. And so it does. So we do know if you're really trying to help your cognition, it's probably not going to help your cognition, right? Can it be helpful for sleep and other things? I think, like I said, there needs to be more evidence of it. And we also know that there are certain types, right? We know that the ones of THC, which tends to be more psychoactive, right, can also be called what we could say entheogenic, in terms meaning that for some people, not everyone, it can actually produce a lot of anxiety. And I've had a lot of patients who, I had someone who came in, they're like, help me with my anxiety. And I was like, let's cut back the cannabis first and then we'll see. And then she went, so I did not need that anti-anxiety medication after all, right? Whereas things like CBD tends to be kind of less entheogenic. But then again, people say like, well, I don't know if it works for me, right? So the evidence is still kind of out there. So it's hard for me to say one way or another because we don't have those high quality studies yet.
Thank you so much. I'll ask one more and then we'll have time for one more from the audience if we need. excuse me, if you have a question. We didn't talk much about the shortage of geriatric psychiatrists, and I know some of the solutions to a lack of MDs, nurse practitioners became more popular, things like that. Are geriatric psychologists similarly short in supply? Do you see them as a potential solution to getting more treatment options?
That's a great question. I would love more geriatric psychologists, like period. We need them because it's hard enough to see me. Having a geriatric psychologist to be able to treat some of this with appropriate age appropriate therapy is also really hard to find. I am super lucky that I'm at UCSF and I had a really wonderful geriatric psychologist. She left but found me her replacement. And I'm super duper lucky. And I'm really lucky that I have a geriatric psychologist who's skilled enough to do neuropsychological testing for me. So if I do need a more definitive diagnosis of dementia, she can help me out with the testing. And I know the VA actually does a really great job of having programs of training geriatric psychologists. But it's, again, just like geriatric psychiatrists, it's not for everyone. I think it takes a very, well, I'm going to toot my own horn. It takes a very special person to really enjoy working with older adults. I think you just have to have that patience, not scare very easily, and you just kind of have to really love the population. So I think it is tough. And so if you could convince some people to go into that field, that would really help me out.
Love it. Any last questions in the audience? All right, I'll ask one more before we wrap up. Related to dementia, we talked a little bit about, I would love to hear a little bit around diagnosis of a specific type of dementia. So in my experience, sometimes you go to one doctor and they give you one type of dementia, another doctor, they give you a different. I know someone who had 4 different diagnoses. So why might that be the case, and how important is it to really narrow down what type of dementia it is in terms of treatment?
I love that question. And you could do a whole fellowship just on that question specifically. And that's why I gave everyone the shortcut of like, if you have to guess, 75% of it's going to be Alzheimer's. But it is hard. And there's a whole bunch of subtypes. And the reason why it's tough is up until like a few years ago when PET scans got a little bit better, the gold standard to definitively diagnose dementia was on autopsy, brain autopsy. And so, yeah, so it's kind of like you kind of have a good guess, but you don't really know until, post-mortem. And then the other thing is that a lot of times people don't bring in family members or the patient doesn't come in until they're a little bit more advanced in the disease. And so what happens is, and I say it's almost like a fingerprint, very, very early on, you almost have to know what those first symptoms are. The problem is that people don't always know when they start to slip, right? And because I almost say it's like cancer, because at the beginning they have their own what's called neuropsychological profile, meaning that those cognitive domains all are a little bit different, and so it looks different for those different types of dementia. But as you progress and more parts of your brain get affected, right, it all starts to look the same and it gets undifferentiated. And so it kind of matters of like when the person comes in, what tests that they got run, and what it looks like. And so I could very understandably say how you might get 4 different diagnoses depending on what time point someone's getting diagnosed. And then some of them are just very subtle and just like this little thing is different, so you got this subtype versus that little thing is different. So people spend their whole careers trying to subtype dementias. Yeah,
I believe it.
And it's not exact.
Great, thank you. We have one question on the computer, and then we'll wrap up this section. Hold on online, we're just testing the mic real quick. Do you want to go ahead and say it, April, and I can repeat it? I will try to capture all of that. Often adults with cognitive or psychiatric issues do not qualify for medical treatment, but they hospitalization, but there are safety concerns. What do you suggest in those cases?
Yeah, that is such a tough question. So these are the patients that come to see me. These are the patients who kind of failed a lot of things along the way and now are coming to see me because everyone doesn't know what to do. And these are the hardest cases because you get families who are just pleading for help. Someone is just out there and they're not safe, right? And so a lot of times it's we start with kind of caregiver training. That's sort of like step one. Caregiver training. How do you not antagonize somebody and how do you redirect someone? And the Alzheimer's Association actually has some great trainings available to people. Like you can call them as a doctor. I could almost like write a quote unquote prescription and refer them to. So so step one is a lot of caregiver training, right? And like, how do you deal with this? And there's some things you could kind of say like, oh, that's really understandable. For example, I get calls from nursing homes all the time. They're like, so and so's aggressive when we bathe them. And if you think about it, not letting someone kind of touch you when you're undressed is an overlearned skill. And we have learned that in our entire lives. It's almost like a reflex now, right? And that's a hard thing to break, right? And so you kind of almost have to weigh your options like, well, how much is bathing today worth, right? Well, what can we do to make someone feel safe? And what I often say to people is, don't contradict people on facts. I see a lot of family members saying like, you already asked that question, or no, you're wrong. It's like, don't respond to the actual content, respond to the emotions of it. And that actually goes a lot further because it's kind of like what that person's really trying to tell you is that they're scared. They may no longer have the vocabulary or the ability to tell you that they're scared, but they're still conveying that emotion to you. So it's like maintaining eye contact, talking softly, trying to redirect them so they do feel safe, right? And that's going to be different for every person. And then there are a lot of kind of environmental things that we can do too, like people who are wandering, putting locks on their doors, putting like alarms on them. And I think we had someone who we had to like track their credit cards or like confiscate their credit cards. So there are a lot of the top things to do are really just our behavioral things. We could spend a whole day talking about that. And it's usually when people come to see me, all of those things have failed, right? And then we need some kind of psychiatric or pharmacologic intervention. But the best way to start is learn how to respond to the emotion of it. So that's the best advice I could give for someone who's not a health trained professional.
Absolutely. And it's very hard being a caregiver. It's very hard being a family member, especially if you're not in the same household trying to observe these things and address them. So we can talk a little bit more about that later. But Alzheimer's Association also has support groups for caregivers and things like that I've heard have actually been quite helpful. So thank you so much. Panelists, you can go ahead and return to your seats, but we'll have Avonelle and Joy come up. Alan's going to do their introduction, and we'll take it from there. Thank you so much, Dr. Duong.
Thank you, Dr. Duong, for providing so much key information. In addition to the research-based knowledge shared, understanding the lived experience is crucial. Today we are joined by Avonelle Hanley-Mills and Joy Abounds from SOLVE, sharing our lives, voices, and experiences. Avonelle will discuss SOLVE and the issue of mental health stigma, followed by Joy sharing some of her personal experiences. Note that we won't be having a separate Q&A after this session, but Avonelle and Joy will be joining the Q&A panels throughout the rest of the afternoon. Avonelle, I'll let you start things off.
You. SOLVE, Sharing Our Lives, Voices, and Experiences is a program of Mental Health Association of San Francisco. SOLVE is a peer-run program, stigma elimination, education campaign, and speakers bureau. We are a diverse group of persons in the community, and SOLVE peer educators share their powerful mental health journey of triumph, challenges, successes, and stigma experience throughout their lives. The real life stories affirm mental health recovery is possible, and challenges do not define a person's worth. Many of the stories that Solve Peer Educator share is about stigma, and we focuses on three type of stigma: self stigma, public stigma, and structural stigma. And one of the reasons why we break down the stigma is because generally you hear, I felt stigmatized, but we're not, we don't hear exactly how was one affected by this particular type of stigma. And our self stigma is oftentimes influenced by society, what society imposed on us. And in our mental health journey, that's very crucial, because oftentimes stigma does influences one to not seek medical attention, and in all cultures. And sometimes you'll hear someone say, in, a person of African descent, a person of Latin descent, Asian descent, in my culture, it's in every culture that in terms of stigma of mental health exists. As a person born and raised in the Caribbean, there's that stigma. And I identify as an immigrant, and it is in the immigrant community as well. Because for me, coming from the Caribbean, filled with lots of community contact. And, I often tell people that it's very religious. We have a church on every corner, every denomination, and mostly it's Christian. And, if the sun is shining, we say, thank you, Lord. If there's a thunderstorm, we say, thank you, Lord. um, so it's very based on, that type of support. However, we also have to include what the cultural base is as well. And understanding one's culture and how that support is given is critical. And so really looking at, how does stigma affect the older adult? As a person close to their 60s, I know I look 25. I've definitely felt, my aging in terms of my mental health, and what do I need to do to maintain or improve my own mental health. And having a family who half of my family is over the age of 65, and my mother is 88, and the oldest person in my family, my aunt, maternal aunt, is 91. And having that experience lately, being a caregiver to my mother, who's very strong-willed, seeing how that her own mental health was affected because she had to have hip surgery, from someone who is very active to not really being active. And what I needed to do to advocate on behalf of her own mental health, and really started to work with some of the consumers in the rehab center, because there wasn't someone talking to them about their own mental health and what that looks like, right? And I took in my dog, who she loves being pet, and that really helped just improve the self-esteem or self-concept of persons now not able to move, who were very active, including my mom. And so what I realize is, we have to start talking, we have to start speaking. And in that generation, speaking about mental health, first, the vocabulary. Because when I told my mom mental health, she said, what are you talking about? I'm not crazy. I'm like, no, I'm not saying you're crazy. I'm saying that your mental health has declined because you're not doing as much activity as you used to. And, you're feeling not being mobile as you used to. Now you have to use a walker, which before she wasn't using a walker. And I signed her up for psychotherapy, and she refused. And then she didn't refuse. And I told her it's part of her treatment. And she did. She enjoyed it. And most of the time she talked about me, but she told me that she talked about me. I don't think she did. But I think it's okay for us to encourage our older adults to engage in activities that in the past it was stigmatized as something being wrong with them, right? And my mother has never spoken to someone in terms of psychotherapy. She's never. And the fact that she was able to have those sessions, and they were virtual, and I'm really glad they were virtual, because I don't think I would have been able to get her to go. They were in her room and she felt safe. And I'm so happy that is part of a treatment plan right now. And so, Solve, sharing our lives, voices, and experiences. How do we begin to share our story? And in all cultures, story sharing is how we have moved from generation to generation and sharing who we are. And this is how improving our mental health and increasing who we are mentally. And I'm almost 60, so I'm pausing. What does recovery look like as we get older? And that's the thing. The more we talk about it, the more we feel open and build our self-worth in terms of seeking support. When we speak about it, we're sharing our story. We're opening up an avenue for others to give us suggestions and ideas and support. I learned that as I spoke about some of the challenges of sleep, that I had food allergies. Now, if I didn't speak about it, I don't think I would have known. And this was not from a doctor. This was actually a friend who was a nutritionist. And so as we share stories, I'm going to introduce Joy Abounds, who is one of our SOLVE speakers and has been speaking about with SOLVE for a very long time. And Joy will share challenges, successes, and her journey in mental health.
Thank you. Good afternoon, everyone. Thank you for showing up and being here to listen to this incredible day of activity and knowledge being shared. Before I start my story, I would like to tell you that we are fortunate, all of us, to be alive. And despite all the problems, trials, and tribulations we go through, we are on this earth to go forward. Without further ado, I would like to say that once upon a time, back in another day and age, when I was in my mother's womb, there was some trauma going on at that time. There was some toxicity going on. And my mother discovered that her mother was going to be dying shortly. And due to this situation, my mother was traumatically traumatized over the situation that was occurring while I was inside her womb. I was traumatized, and I was tossing and turning constantly, making it very difficult for my mother to carry me. Due to the fact that this was happening, I ended up being born and being a colic child, to double it up, and being a very problematic situation, being the first child in the family. Moving on, I matriculated into kindergarten that was supposed to be a positive experience and a happy experience for children like myself. I discovered that was the opposite, because I drew a green apple and the rest of the class drew a red apple. I was ostracized and looked down upon and was reprimanded by the teacher, and my mother gave me a a very difficult time. I grew up with a green apple tree in my backyard, and I ate green apples constantly all the time. But yet I was not accepted to draw a green apple. Okay, let's move on. Third grade happens, and I am considered to be a slow learner, what they called in my day dumb, D-U-M-B. I had to stay back because of my being dumb and did not get to move on. Therefore, I was very uncomfortable and hated school tremendously. Moving on to fifth grade, I was physically abused, and I'm not going into it. And my mother said, this is it. I'm taking my children out of the school because my brother and I both stayed back and we were not smart. So I went to regular public school from a private school into the sixth grade and made the honor roll. Just like that. Now tell me how that happened. All of a sudden I'm smart. Gee. Okay. Moving on to high school, I was very unhappy with all the past history that I had experienced and didn't feel like I wanted to live anymore. Therefore, I moved on to looking for a way to take my life, and consequently, the medications were not available to me that I was looking for. So that went aside, and I desired and dreamed one day to leave East Coast, Connecticut, and get away from the racial tension and the discrimination that I, as a person of color, faced. And therefore, I did dream that California was in my future. And at the age of 21 years old, I landed from the airplane in San Francisco. And here I am today to talk to everyone about my life. Now, after I arrived, I was, flabbergasted because everything was so different. And so I was culture shocked by the differences of the East Coast and the West Coast. And I reinstated myself in college. I did graduate from college and, had no problems in school, and I wasn't really dumb. I was quite bright. I found out through all the years of being called a dummy and standing in the corner, I got a little bit uncomfortable with, everything being a newbie, having no friends, having no family here, being all alone. And I started to get interested in shopping. And when I was shopping, I was thrift store shopping. And I was collecting, and what is now called the collector behavior, and in the past they called hoarding and cluttering, and ended up getting too much clothes and too much this and too much that. And I didn't realize that my apartment wasn't really big enough. So then I had to get storage and I had to move on to that. And in any case, I became problematic with a problem of too much stuff. And you know what that means. And that means that you could lose your apartment. And I had a problem in that situation, and that got ascertained. And, I am now moved on into a senior housing, and I am living in a different environment, and I have a very, very feng shui place. I try to be minimalist as much as I can because I don't like a lot of stuff anymore. So what has happened on my journey? How have I survived the trauma, the drama, and toxicity? Well, I'm a strong person to begin with, and I'm very self-sufficient and always been independent and single. And I think I've had to fend for myself all the time, and I never had a backup or a partner, and I've not been ever codependent. But I have the zest to survive and live. I really realize the older I get how important life is, and I need to wrap it up because my time is being told to me. So I would like to thank you very much and say thank you for listening, and I hope you got something out of it. Thank you.
Real quick before Alan finishes up for this, we will have Joy and Avonelle on our Q&A panels for the rest of the afternoon too, so you can feel free to ask follow-up questions then as well. Alan?
All right. Thank you both, Avonelle and Joy. At this point, we're going to take our 10-minute break before returning for the second half of the seminar. Beverages are available down the hall. Restrooms are down the hall and to the left after passing the beverage station. If you did not get a chance earlier, we invite you to sign up to receive our quarterly e-newsletters on the sign-up sheet on the back table. You can also find more information about People with Disabilities Foundation and useful handouts on that same table. We'll see you guys back in 10 minutes. Thank you all. Okay, everybody, welcome back. Thank you for the making your way as quickly as possible. I know it was a very short break. I'm now going to introduce our next speaker. She's an attorney, Janet Espy of Espy Law Offices. Ms. Espy has practiced in the areas of estate planning, trust law, and probate since her admission to the California State Bar in December 2004. She's a member of the California State Bar's Trust and Estate section. Areas of particular interest include working with clients and their families during life transitions, representing clients with changing mental and physical capacity, and planning for beneficiaries with special needs. Please be aware that Ms. Espy cannot give individuals legal advice at this seminar. And now I would like to welcome Ms. Espy to the podium.
Good afternoon, everyone. Thank you. And thanks to the other speakers, I've really been enjoying this seminar so far. Oh, thank you. All right. Okay, thank you. So I want to talk to you about mental health considerations when navigating end-of-life planning. And oops, I went the wrong way. Sorry. Okay, so what the topics I want to talk about is what is end-of-life planning, giving an idea of what sort of topics, legal topics that covers, basic estate planning documents, requirements including cognitive requirements for establishing legally effective estate planning documents, alternatives to estate planning documents. This is for planning when you'd like to start having someone help you, but maybe aren't prepared to totally turn over access to assistance. So some of the things you can do for allowing someone to help you, and also, to name beneficiaries without having to do specific estate planning documents. And then what happens when there are no estate planning documents or other arrangements in place? And then mental health considerations and tips for starting the conversation about end-of-life planning. So what is end-of-life planning? A lot of times people think about that as just plain, who's going to get my property when I pass away? Yeah, they think about dying and maybe having someone to handle their affairs and who their beneficiaries might be. It's funny to me sometimes how people, it just doesn't occur to them that there might be some planning involved with aging, where you start to need more help. There's capacity changes that occur that Dr. Duong spoke about in great length. And there's also very sudden changes that can occur in your ability to manage your affairs. That might be a sudden medical condition, or maybe even an accident, something unplanned for, where you have an injury, where you're not able to do things. So Dr. Duong talked about the baseline, and a lot of us have our ways of interacting with the world, maybe what we do and don't understand, how we manage our finances, maybe with help, maybe not. We have people that we go to for advice and do things. The sort of planning that end-of-life planning involves is thinking ahead for, well, what should happen when my baseline changes? If I'm not, if in some way I'm not able to, explain what I want, or if I'm not able, to actually do my own business for some reason, like pay my own bills or do things like that. Legally, when I'm working with clients on this, in addition to looking at cognitive changes as a part of planning, there's another aspect of it that it's called undue influence, and inability to resist fraud and undue influence. And when I was growing up, we used to call that street smarts. Someone comes up to you with a real fast talking story, and you can kind of okay, I'm not going to give this person $50, to go over, to take a cab somewhere. But sometimes you don't have cognitive changes, but your ability to kind of filter out, what someone's telling you, and your ability to have a little cynicism or that can really lessen, to where you become vulnerable to that. So the focuses are there's kind of two general areas. One is to plan for managing your finances and assets and business matters. And then the other is naming someone to act on your behalf for medical treatment and things like making decisions about your residence. It's also really important to make any instructions you have regarding medical treatment, and then name beneficiaries for receiving your assets after your death. Often with that sort of planning, you might need to plan for ongoing management for your beneficiaries. If you have children, maybe that are minors, or if you've got a loved one that has a financial situation where it might be benefit to set something in particular up for them. A lot of my clients have loved ones who receive public benefits, or they qualify for public, and there's a lot of planning you can do to leave assets for them that won't interfere with the eligibility for that. So that sort of planning, thinking ahead for the other people in your life, and then ultimately, by doing this in advance, you can make it a lot easier for people to help you and carry out your wishes. And you can also avoid some of the procedures that are in place for when you don't have documents. I'm going to talk about those in a little bit, but you can make it a lot more streamlined and less expensive for the people that are helping. So let's see. Okay. Basic estate planning documents. There are 3 basic documents, and then the 4th is a revocable trust that I'll mention in a minute. But the will is what a lot of people think of when you think of estate planning. You see the movie, maybe someone's in their deathbed and everyone's around, like, put me in the will, or I should be in the will, or whatever. Or you might have the reading of the will, after someone's passed, everyone's there to hear what does the will say. So it's funny, some people love that idea and they spend a lot of time, they'll call me, okay, this person's out of the will, and they'll tell me what the wrongdoing that the person did, or they'll say this person's in, and it can be enjoyable for a lot of people to plan that. You also, with your will, name one or more individuals to manage your business. They file your final taxes, they handle paying any bills of yours, and take care of carrying out your wishes. The will, while it does name someone to manage things for you, it really is a document that only goes into effect after you've passed away. So it's just one part of planning. The next document, the durable power of attorney for finances. This is a document where you name an agent to manage your affairs for you. And it can be either immediately effective, it can be very flexible, it can be for a limited purpose, or it can be a general purpose. It's effective only during your lifetime, and the authority under this ends at death. And I like to really stress that, because so often I have people come to me where they're, well, I have this durable power of attorney, they're not letting me into the account. Shouldn't they be letting me into the account? It's like, well, no, they're not allowed to let you into the account because your authority ends with that. So that's an important piece of things. It's rare nowadays with all the technology we have, but I still occasionally have a client that will say, I'm traveling overseas, I want to name someone do a particular thing for me while I'm gone. But nowadays people really use this more to plan for changes in their cognition, for when they're not able to manage things for themselves. And then the Advanced Healthcare Directive, this is where you designate one or more people to act as agent for your healthcare. You document instructions regarding your medical care, and it lasts during your lifetime. In California, the person named as your agent is also the one authorized to dispose of your remains, and they can authorize an autopsy. So there is some authority that continues beyond death. And then the revocable trust. This is a document that for the assets that are transferred into it, it's very similar to both the power of attorney document and the will, in that it for the assets that go into it, the document dictates what happens at each phase. What happens when you become incapacitated, who the next successor trustee is. That would be the person managing your assets. And then you describe what happens, when you pass away. And the trust can even continue on, for a period of time where you have subtrusts, for children or other beneficiaries that continue on. And it's a really great way to plan when you have a lot of instructions or there are concerns about maybe not wanting to give assets outright to somebody. So California, the revocable trust is a huge tool in California for avoiding probate. Probate is a process that occurs when you passed away, that it occurs in the Superior Court Probate Department, hence the shorthand, people call it probate. But there's a court supervised process where notice is published that you've passed away. There's a space for creditors to come and file claims, and it's all supervised. Your heirs are determined, or if you have a will, it's admitted, and the beneficiaries are confirmed, and then everything's administered and distributed. Having assets in trust will avoid that court process. So one big benefit of the legally effective documents is that they're really intended to be comprehensive. The authority that you grant to the people in the documents, it's a blanket authority. If you can present a valid document, a third party is actually required to accept it at face value, and turn over assets in an account, allow you to, for some reason, changing your channel lineup is like, they think everyone, I don't know, you try to do that for a parent or another elder, somebody, they act like you're trying to break out like all their assets. But you can, sometimes the companies where you're trying to change the accounts, they won't let you do it, till the person authorized, whoever's on the account, that'll let you handle that sort of business. I like to think of it as actually kind of stepping into the person's shoes. So you get to act in place of them to do that. So the third party recognition is very important. And then also really important with the documents is the people named in them. There's a lot of legal protections in place for you when you name somebody in your documents in that capacity. In California, there are multiples of damages. If someone was acting as your agent or your trustee and they took your money, not only do they have to pay you back the money, but they might have to pay you back 2 or 3 times what they took, plus any money they made off of it. And there's also criminal liability, if somebody violates their duties to you. So those documents give you a level of protection. So, okay, let's see. So requirements for establishing legally effective estate planning documents, they are determined by state law. So each state has usually capacity requirements, what they're looking for someone to be, competent enough to sign a particular type of document. And then there's also execution requirements. Execution requirements are really based on trying to avoid fraud. It's an area of law where my clients are always disappointed they can't DocuSign. It's actually an area of law where you get the wet signature. If there's a question about whether a will is valid, they might even date test the paper. And it's really interesting the sorts of things they'll do to make sure. They'll study if something's a little off in a copy. Sometimes that's a classic to say, well, we lost the original and then here's the copy. That so the execution requirements are meant to kind of help protect that. So if you're interested in estate planning, it's really important to find out the legal resource or consult an attorney in your state. And if you're working from the internet, be really careful that the forms are state specific. California has a number of forms available for free that are put out in California statute. They give you the language and you fill in the information, and they publish those with all the instructions for properly doing it. That's meant to encourage people that maybe don't want to go to an attorney or can't afford to go to an attorney, to have the basic document. So if you're looking to do something, it's really helpful just to remember the state. Be focused on your particular state, and don't be shy about calling an attorney. I'm always happy to look at people's documents that they've done themselves. I'm very happy to do that. You can buy 15 minutes or a half hour of somebody's time. And it's a good investment. When you do work with an attorney, it's sometimes attorneys and notaries that some of the documents require notarization. There might be some duties and obligations that those professionals have to kind of protect you when you're executing documents. So let's see. Okay, one of the things I just like to mention, because for people, I really enjoy working with my clients that maybe have some maybe atypical cognitive neurodivergent, different situations. And when you do estate planning documents, depending on the type of document that the person is signing, the legal capacity, there's a real push to try to honor somebody's right, to name someone to help them, to have this sort of assistance, and also to be able to name their beneficiaries. That's kind of a basic right that we like to recognize, at least here in California. And the sorts of things, if maybe you have a situation where you rely a lot on somebody to help you, even to help you with decision processes, the capacity to do some of the estate planning documents are a lot more flexible. Oh gosh, 1 minute. Oh, okay. I will, let's see. Alternatives to estate planning documents, and I'm hoping we can just put these slides up on the website. Oh, okay, sounds good. So we'll put this up. These are some suggestions for you about kind of estate planning light, how to get someone to kind of start assisting you if you want some help. And, okay, let's see. Okay, so mental health considerations and tips for starting the conversation about end-of-life planning. I know this kind of dovetails with one of the questions we had during the break there, but end of life planning, it can be very triggering for people. If there's any family disappointment, loss, fear of, just people have a lot of anxiety about the idea of turning things over. It can really make people uncomfortable, and it's especially it's all part of you have your adult life and you're feeling you have your status quo with how you're managing things, and that maybe starts to change. And a lot of people don't think to plan until maybe there's been a crisis or some sort of obvious change. And often it's a loved one that's really pressuring, to say, look, you need to have a power of attorney. Let us have power of attorney, or let us do something. It's, this is something where allowing someone over your finances or medical decisions, it is a vulnerability. And I had one really elderly client when I called her to talk about making a change to her document. She didn't recognize me right away, and she was like, well, I'm fine, with my document. Like she had that kind of conditioned in of don't change the documents. Like if someone's, and I was like, oh, A+, but yet, we need to work on this a little, and I kept talking with her. But it is something often people really have worked hard to be to be independent, and it can be frightening to think of that. I think one of the things that's so important when you're approaching someone about offering to help them is to really have the right attitude about it. Getting the authority over someone is really to carry out that person's wishes. It's not the time to make them break up with their partner that you don't like. It's not the time to make them quit smoking, or to do these lifestyle changes. It shocks me sometimes what people think, like, oh, I'm their medical power. I'm going to block the visitor, at the hospital. People can tell if you're wanting to control them, and I think kind of having your mindset right is important. Explaining what will happen if no planning gets done, it can really get taken out of your hands. I didn't really get to go into that, but some of the court involvement where they impose conservatorships, you might have someone appointed that isn't necessarily who you want. Also with estate planning, you might have somebody named by law as your beneficiary or heir that isn't who you want. So it can be really helpful to know kind of what's going to happen if you don't do anything. You may need to bring up the subject more than once, and I think as professionals, it can be helpful. I sometimes have clients come to me that say, oh, I was there for my checkup and my doctor said, do I have a power of attorney? Yeah, which I love. I often am asking people about their health directive, and they'll say, oh, my doctor had me do one. So it is helpful to kind of just be mindful when asking people, or talking to people about their support system. Do they also have these kind of basic things in place? So yeah, I think, yeah, that's a good stopping point. So thank you. We're sitting down.
All right, we're going to do another Q&A as our speakers go ahead and come up for this topic. And then do we have any questions on the computer yet? Nope. Okay. Any questions in the room? Thank you.
Yes, from what I understand, the executor is supposed to submit the will to the court within 30 days. What if he does not?
Make sure it's turned on. Sorry.
That's
It was on. I think.
okay. So what the rule is first of all, there aren't police that police executors, and I think a lot of times people don't know their duty about starting the process by presenting the will. And so, and some families even have a period of mourning where they don't do any of that sort of business for a period of time. So if you don't do it within the time period, typically that's okay to pick it up and do it. But the responsible person, who's the executor, becomes liable for any losses that people have for failing to do it. So if you kind of let it go for a long time, and there's maybe I'm trying, someone could have a lawsuit against you if they could try to argue that maybe there were assets that needed to be sold or things that needed to happen. So that's a good question.
Thank you. All right, I'll go ahead and yes, Joy. Go ahead.
You mentioned about a notary republic, on your. What if you have a close family member who's a notary, allowed to be a notary, but they're out of state? Because I'm in California, but they're on the East Coast. Are you able to use that that person across the country as a notary?
If you travel to New York State or to whatever state that the notary is in, it will be legally effective, but you must sign within the state. So if if I'm notarizing a document in California, I must be a notary in California. And then some states recognize, interestingly, some states allow for virtual notarization, where you can. California does not recognize that, though. So if you, not unless you traveled out of state, you would have to go to the other state. You'd have to physically be there for California law for it to be valid. Oh yeah, no problem. But other states do. Some states allow that. So I, right off the top of my head, I don't have an example for you, but some, California does not allow that.
Okay, great. I have a question while people think of additional questions to ask. You had mentioned how attorneys, and this is specifically, I'll be asking from the California perspective, how does an attorney test for capacity if you're just meeting someone for the first time?
That is such a good question, and I had a whole if I could talk to all of you as long as I would like, I have a lot to say. It's actually very interesting. It was like Dr. Duong's list of all the cognitive areas. Mm-hmm. So, obviously as an attorney, you're not, an expert, but knowing what you're looking for. One of the first things I do is I look at how willing the person is. And if I can, a lot of times I'll meet with them alone or and talk to them about what they want. And the person, it's so interesting because sometimes people are quite ill and they can't communicate, very easily. But if someone can convey that they want someone to help them or to be able to dispose of your assets, you are required to have a sufficient knowledge of what the assets are, and kind of who your main people are, like who you want and maybe who your family are, especially if you don't want them. You need to kind of know who people are and convey that. But the bar is quite low, for that. And then for other documents, like a power of attorney, you have to show. So a lot of times I'm looking at a lot of the same cognitive abilities that a doctor might, like, are they being really repetitive? How's their memory? If I'm uncertain, I may ask them to get an exam, a mental exam, just to bolster the documents, to strengthen them. But in the law, it's kind of interesting because having issues with the different areas of mental processing is just part of it. So you can have those, but if those issues that you're having don't interfere with who you want to name, if kind of what you want to do makes sense, it's a green light for the lawyer. we can go ahead and do the estate planning. If the cognitive issues cause the person to do something that they wouldn't ordinarily want to do, then it's not considered legal.
So I just want to repeat that back to make sure you understand. So basically, if someone is constantly calling people by the wrong names, that could impact their legal capacity to be accurately creating the documents. Whereas if someone just forgets something pretty benign, not really related to this, they forget where your office is located consistently, that's not necessarily related to this.
Yeah, I would even say, if you can identify a common issue I have, maybe I have someone that's kind of lost track of numbers, and we'll talk about, okay, who are your important people, and you think about dividing a pie, kind of the percentages of who gets what, and maybe someone can say this person is the most important, but then I want to remember this other person, but if you try to assign a number to it, they have a trouble, doing that, like the percentage or the number. And so sometimes you can work within that, and if they are able to communicate, if they're able to make it pretty clear what they want, even if maybe the specific words are incorrect, like maybe they keep calling a child the wrong name, if you can kind of figure out what it is. But it's all of that. I know when I'm working with clients, I'm looking for things like that, and I'm always looking at, okay, if I wanted to try to argue that, like, mom or my friend, that maybe wrote me out of their document or put me in, maybe that they didn't have capacity, I look at, I might look for things like that. And so sometimes you might even have more than one attorney, or you might have, as a doctor give an opinion, and things like that. Especially if there's a lot at stake.
Yeah.
Or keeping. Unfortunately, contests of documents it's a huge industry.
Yeah.
Legal contests. So you want to be real careful.
Absolutely. Do we have a question on the computer in the back? Okay. Anything anyone up front wanted to add to that? Okay. All right, question in the back and on the computer, and then we'll go over here. No. There you go.
Can changes be made on a trust without a notary, just writing on the trust and signing next to changes?
I'm going to be obnoxious. It depends. Kind of a lawyerly answer. In California, no. Some states might be. Well, in California, technically, you don't need a notary for a trust, but you do need to have having just handwritten changes that are initialed. That's not valid unless the words alone manage to qualify as a holographic document, and often they aren't, if you're just crossing out a name and initialing it. So it is, I have many people ask me that, or they've done that, trying to update their documents, and a lot of the time that's just not going to work, under the law in California.
Thank you so much. And we have a question over here.
Can one of the heirs, like a child, be an executor? The beneficiary be the executor?
Yes. Yes.
Absolutely. I think anyone can be an executor.
Oh, yes. You can really name anyone to be your executor. I'm just trying to think. Naming somebody, there are some. There's kind of a body of law and some protections in place when you have someone assisting you. So sometimes there is a whole area of law when you have a caregiver or someone that you met because they were providing care to you. or some other assistance when you then try to add them to your documents. And there could be a presumption that that is invalid, you know, because of the fear maybe that the person's unduly influencing you. But, you know, working and just simply having an attorney review it can usually help that situation. And those rules don't apply if the person is a family member or someone related by marriage or someone that you have a pre-existing relationship with. Because it's so common that the person that might be the one you trust to help you is also your loved one, you know, that you want to leave property to. But yeah, that is a good question.
And then we have one last question in the back. Oh,
So
it's on.
Okay.
my parents have an irrevocable trust, and my mom left instructions on how to do certain things with personal property like jewelry and her car. And then she got Alzheimer's, and my dad did contrary to what her trust said. Is there something I could do about that? I did talk to him, and that was not successful.
It's very painful because
Can you speak into the
oh yeah, you know, I'm sorry that you know, that's very painful. And the tools for dealing with that, it's really like coming at it with the hammer. You know, there aren't really fine tools in place, you know, because if somebody goes through, what you can do is sue them for the value. Yeah, you know, and if it's tangible property, often you know, the sentimental or you know, the value isn't really measured by the value of the item. And then it's also really difficult within a family to be in a position to sue somebody, you know, that's a family member. And that can be really common where people, you know, grief can really bring up a lot. You know, like people, anyway, that's just very painful. That sort of thing. I'm sorry. Yeah.
We had more computer questions.
Yes. Is it common to have planning sessions with attorneys videotaped?
Oh, you know, I go to my own continuing education, and a lot of the litigators say, you know what, you're just making Exhibit A, yeah, you know, for the lawsuit. You know, if you have the video, a lot of, you know, if there's a capacity question, it's. I know sometimes people do. Often, if you're at a point where you're wanting to videotape it, it's probably because there's a big question about how, you know, what sort of shape the person's in and what their intentions are. And I think it's really good to get, yeah, sure, maybe videotape it, but get additional support for that plan over time, like having them get a certificate of independent review. If the person can go talk about the same plan with a couple of different attorneys over time, that's very supportive. And if you know, if you can have the reasoning for the plan, I spend a lot of time talking to my clients and take a lot of notes about why, you know, they want to do something, just so I have that. The other thing is, sometimes if someone's willing to go get a psychiatric examination and, you know, get a doctor to sign off and do some things over time, it really shows that is what they want, you know, so it can be a good way. So I would say if you're doing that, don't just rely on that.
Okay. And then we had one more there. We have one in the front, and then we'll be done.
So when hypothetically you have older person who's always been very independent and able to do everything and is losing that ability and needs help, but then maybe they are succumbing to some of these situations you mentioned where they're being not critical enough, or, you know, to discern when something's a scam, for example. That's how as like a person who's helping them is like their power of attorney. How do they help protect the person without taking away their independence? How do you walk that line?
You know, it can be difficult, and I know a lot of times when I'm talking to someone who's looking at that sort of transition, I'll often start with them, you know, you can name the person to act as a co with you. Yeah, you know, like you're the principal under the power of attorney, they're the agent. You know, you can still access all your accounts. You know, so maybe you start off that way, and as the person's comfortable, they might withdraw from managing things. And I think for the person who's the helper, it's really important to let the person kind of make their mistakes, you know, and don't catastrophize it, you know, because a lot of times it's really, people can be really ashamed. You know, I had a client give a $25,000 gift to a fellow at the gas station, you know, and his son found out about it. And he was really mortified when he kind of sat in. So it's removing somebody entirely. You know, sometimes someone, if they have a trust, they might be willing to resign. A conservatorship is a way to, you know, you really stop someone from being able to access their assets. And that can be very traumatic for someone. You know, that they're dependent on the person, you know, the conservator for everything. You know, so sometimes I think it's, you know, you want to help them and try to, but keep some autonomy. That's worth a lot too. You know, the autonomy is worth a lot.
And some solutions I've seen have been maybe some accounts transfer over and not all accounts. Or if you can't have a credit card, maybe they can have a debit card. Things like that can get you in the middle.
Amazing. Yeah. You know, that's actually a really good way to do it. Yeah. You know, sometimes bankers and financial advisors now are really under a new duty to assist. And a lot of times they're really happy to play along. And if you have the two people, they'll call the co-trustee, you know, they'll say, okay, you know, the person's wanting to do this. What do you think? I'll stall them. You talk to them. And, you know, you can have that sort of a protection. And then giving the person their own money or their own credit card where it's a little more contained is fantastic.
Yeah, credit card with $500 limit instead of a $50,000 limit.
Exactly. So
Awesome.
yeah, that's really good idea.
And then we'll take the question in the front.
I gave my mother some advice about who to distribute her jewelry to. And I said, don't decide or don't put it in. Let me rephrase that. Don't let the person decide after she dies. You do it now, before you die. And she took my advice and she put the names of the children in the family on the jewelry. Then she decided, no, I think I'll give them now before I die. And she did. She gave away her jewelry. But give them the personal property before you die. This way, you know who's going to get it for sure. And I think you avoid inheritance tax.
Well, you know, that is such a lovely idea. And I've had some of my clients kind of come up with that solution and they really enjoy it. Yeah, you know, they enjoy explaining what the item is and why they want to give it to the particular person, you know, and that's lovely. For transferring assets before or after death, you know, if you're trying to kind of avoid taxes, they get you. Yeah, you know, the value of the assets, they have gift and estate taxes. So they'll kind of get you one way or the other, depending on the timing you try to do it. And if it's too close to death, they might even sweep it back into the value of your estate. So, you know, fortunately, the amount before estate taxes are imposed is, I think it's about 13 million plus this year. Next year, it's going to go down to around, I think with inflation, it's going to be 6 or 7 million. I see the two different numbers. That's going to happen next year per person. Yeah, you know, that you can, I mean, each individual may leave that much before there are transfer taxes. So
right,
Well, it
the-
wasn't to avoid inheritance tax.
Oh, yeah.
I mean, she's still alive.
Yes.
And this was years ago
Yeah.
that I advised her to do that. So
Well-
it's not close to death at all.
Oh, yeah.
Yeah.
Well, I think it's lovely, and that's such a good idea, and it can be something to do over time too. For holidays.
Mm-hmm.
Yeah,
That's what
really
happened during
special.
the holidays. She distributed her jewelry to us.
Yeah, and you're allowed to give a certain amount each year to individuals before you have to report it. And this year it's 19,000. So even if you're giving a really nice piece of jewelry, unless it's like $1 million engagement, something really wildly expensive. Usually that covers most people's items, that they give.
Thank you so much. Thank you so much. We will go ahead and have everyone return again later, but we'll move on to our housing section now.
Again, thank you, Janet. Our next section addresses some of the housing issues that may arise for older adults with psychiatric disabilities. The various housing options, personal needs, and how costs can be covered are wide-ranging. For example, people who stay in their homes, whether owned or rented, may need some level of caregiving in order to continue to live at home. Private in-home caregivers may cost roughly $40 to $50 per hour, which can be cost prohibitive for most middle-income adults. Some people buy long-term care insurance to cover the cost of caregiving. Depending on the terms of the policy, it may cover services at home, in a nursing home, and/or in assisted living. Medicaid, the poverty program, allows long-term care services in a variety of settings. From institutional care to community-based settings, some Medicaid services may differ in different states. For example, Medi-Cal, which is the Medicaid poverty program in California, covers some in-home caregiving through its in-home support services, or IHSS. Our next speakers will discuss securing homes and ensuring rights, addressing housing challenges for adults 65 plus with psychiatric disabilities. Abel Mouton is a staff attorney and legal assistance to the Elderly's Housing Preservation Unit, where he advises and represents seniors facing eviction, many of whom have psychiatric and/or cognitive disabilities. Mr. Mouton cannot give individualized legal advice at this seminar, and Kristen Acevedo currently serves as a support services manager at Tenderloin Housing Clinic, where she supervises a team of 11 case managers across 5 permanent supportive housing sites in San Francisco, including a senior housing facility with 75 units. She and her team provide support to adults who have experienced chronic or long-term homelessness, mental health challenges, substance abuse, and trauma as well. I'll leave it to Abel now with his presentation.
Hello. My name's Abel. I work at Legal Assistance to the Elderly, which is here in San Francisco. We provide a wide range of legal services to people who are eligible for our services. So it has to be people that live in San Francisco. They have to be 60 years or older, and they have to, or they can be a person with a disability recognized by the state. That's who our population really is. So there's a fairly significant overlap with the discussion. So if I press this forward, it goes forward, right? Oh, overview. All right. So I've been asked to. So the overview of my talk. The first is going to be tenants' rights and responsibilities. So that's going to cover sort of preventive care in this situation. I was asked to provide an example of what the landlord's point of view might be on a nuisance case. It's not something that I'm very well acquainted with, but I hear from them a lot. So, there's going to be a point on what I wish you knew before you moved in as an eviction defense attorney. There's going to be a section on competing interests. a section on accommodations, and finally a section on settlement. So all of this stuff kind of mixes together, but we'll cover it all. So basically, I work in LA's Housing Preservation Unit. I'm an eviction defense attorney. So all I do all day, every day is defend people who are facing eviction. There's no income threshold for our services. So no matter how much money you can make, you can come get legal services from legal assistance to the elderly. However, our clientele does tend to skew towards the bottom of the pay scale for the most part. It does happen though. We do get rich people occasionally. And many of our clients are in public housing, which often will have its own set of concerns. So the first section is tenants' rights and responsibilities. So I guess a way to think of it would be that there's a sacred trust between a landlord and a tenant. And that sacred trust depends on the tenant paying their rent every month on time and in full for the duration of the tenancy agreement. And in exchange for that, the landlord will let them live in whatever premises are defined by the settlement agreement until not the settlement agreement, the rental agreement, until it expires. So basically, all of the tenants' rights will depend heavily on whether or not they're continuing to pay their rent regularly. The other thing is you can't intentionally damage the premises beyond regular wear and tear. And there are disputes about what that might mean, and that's part of my job, is disputing what that might mean. Typically, the position that I take is that anything that comes from just living in the apartment, that you're not responsible for. But if you're going to do something more like light a fire in your kitchen, if you're going to try to have a barbecue inside, if you're going to pour concrete down the toilet. Is that going to help? All right. And so the third thing is live in peace with your neighbors. There's lots of stuff in the law about what all of these things mean, and they're defined pretty granularly, but those are the main things that it's really hard to evict a tenant who's paying their rent on time and in full every single month, not intentionally damaging the premises, and that they live in peace with the neighbors. And so what the tenant gets out of that is they can live in that premises defined in the rental agreement, and that the premises must be habitable. So that means the landlords are responsible to make repairs for all kinds of things. There's a list in Code of Civil Procedure 1941.1. What does it take to make an apartment habitable? What does it take to be someplace that a person can actually live? There's a certain amount of common sense involved. It's going to be things like water, heat, different kinds of utilities, access, garbage, and these are listed. If the landlord's not doing that, they're not fulfilling their end of the agreement, and you should sue them. Let's see. Right. So this sacred trust, one might assume that it is saying something about reciprocity, which isn't really happening from my point of view, because if you look at this, then what a tenant is paying for is they're giving a significant portion of their wages or whatever their income is that comes in every month in exchange for a temporal use of a housing facility, and the landlord takes that money, the tenants, and then uses it to build equity in their assets. And the tenant just gets that 1 month in the property. Let's see. Oops, that was the wrong direction. Landlord point of view. All right, we'll get to that in a second. The other piece that suggests that reciprocity isn't as big of a deal as some might make it out to be is that the landlords in California have been given what's called the summary procedure. And it took me a long time before I finally got someone to explain that to me in a way that made sense to me, which is basically that the state, in its wisdom, has decided that it's so important for a landlord to be able to get their property back if a tenant is not living up to their end of the agreement, that they've given them a very rapid court procedure that allows them to do that. So the first thing is that tenants are not allowed to sue a landlord back. So if a landlord sues you for unlawful detainer, you can't sue them back in that case. You have to have a different case. How many of my clients would like to sue their landlord back? Every single one of them. But that's not available in this procedure. The other thing in this procedure is that all of the deadlines are pushed up. So it's way faster. They just got a little bit longer, but typically in a civil case, you'd have 30 days to respond to a complaint. Whereas in an unlawful detainer, it was 5 days to respond until January 1st of this year. And now we have 10, but we lost some other stuff that we liked.
We have a quick question.
Yeah. Later, okay. Let's see. So this thing about paying rent, I don't know if I've made it clear how important that is. But sometimes, there is a certain, in public housing cases, there is a certain amount of distortion that's been that has entered that process, specifically because so many of our clients in public housing are receiving partial or complete subsidies. So if our clients stop paying their rent, it might take the landlord a long time to notice, and but they can notice for non-payment as soon as the client is late on rent, past whatever the date defined. I think it's usually 5 days. So the law basically says is that except for in a few specific circumstances, there has to be a good reason to evict the tenant. And the first good reason to evict the tenant is that tenant has not been paying their rent. So a landlord can, as I said, they can file on that. They can give you an eviction notice as soon as you stop paying your rent on time. The second is nuisance, which I think is what I'm going to talk about more today. So a nuisance is defined as substantial interference with the comfort, safety, or enjoyment of the landlord or other tenants in the building, the nature of which must be severe, continuing, or reoccurring in nature. So I talk a lot about how severe things are, or whether or not they're recurring enough or continuing enough. The actual case when a landlord seeks to evict a tenant is usually a combination of one of these three things: the non-payment of rent, the nuisance, and the third thing that I didn't say yet, which is a breach of the lease. The easiest one by far is the non-payment of the rent. So a lot of times I'll get a non-payment case that looks like it's a non-payment case, but really it's someone who smokes in the fire escape or something like that. But they can't, it's harder for them to prove that. They don't want to go to the work for proving that, so they go for the non-payment case. And so that's going to matter later on, because what they're really after here is some form of a settlement agreement. So I was asked to give the landlord point of view with the example of a nuisance case. This client is a disabled senior who uses a wheelchair. He is a Vietnam veteran. He orders lots and lots of stuff over the internet, including food, clothes, tools, and toys. Most of the stuff that he gets over the internet stays in boxes that pile up in the unit. And some of this stuff is some of these are perishable items. The whole unit is a mixture of empty and full packages. The daily deliveries are a point of contact between the client, other tenants, and building management, with client frequently becoming incensed about how their packages have been delivered and whether or not he receives them, and he yells all kinds of racial and sexual epithets into people's faces. Client hates management so much that he refuses to complete his annual recertification for his subsidy. Client has a paranoid fixation on a couple of other tenants and the janitor, who he believes are engaging in all kinds of nefarious activities ripped from the headlines of the daily news. Most of clients' rent is paid by a subsidy, so the client is in the habit of never paying his share of the rent and then just getting rental assistance on a more or less annual basis to cover the arrearage, which is usually $1,500 to $3,000. What do you imagine the landlord's point of view on that tenant is? Can you guess what he was eventually evicted for? He was not evicted. We won every time, over decades, we won every time. So what I really wished that a tenant knew before that they moved in, that's how long I've been talking or how long I have left? Okay. So I get a lot of clients who come in and something is wrong with their apartment, so they have stopped paying their rent. So what I really want tenants to know when they come to me, and so a lot of times the tenants who have stopped doing that are people that are hard to tell this kind of stuff to. But you can't unilaterally stop paying your rent. Tenants who do this are easy to evict for non-payment. A lot of people have heard that the habitability requirements of an apartment mean that a landlord is supposed to make sure that all this stuff is happening all the time, which is true. The landlord, one of the steps that my clients tend to skip for a number of reasons, is informing the landlord that these conditions exist in their unit, and then they just stop paying rent because that stuff isn't taken care of, and then they get a non-payment notice. The next thing that's very important is tenants cannot deny their landlord entry if it's properly noticed per state law. So the state law just says that they need to give reasonable notice. And so there's some dispute. You can dispute what reasonable notice is, but over a period of time, it's come to be accepted that that's pretty much 24 hours. It's not enough time for a lot of clients, and many of my clients are under the impression that the landlord doesn't really need to come in to do a repair, or whatever repair the landlord is going to come in to do is not the repair that they need to do. They're going to come in to take photos of all the tenant stuff, and so they can do terrible things to them later. But that's not a reason to deny the landlord entry. If the landlord enters properly, or the landlord notices properly, you've got to let them in. And that's just with the thing that says on the door. And a lot of times it'll also say something like, if you don't let them in, if you don't let us in when we come, then we can evict you for that. Yes? So the question is, are landlords allowed to take pictures when they come in? I argue no, but a lot of times they come in and they do it anyway, and then they already have the pictures. So you can sue them to get the pictures back. There's not a lot of there's not a really a remedy for that I'm. Right, you can deny them that situation. It doesn't mean that they won't take pictures. But it might mean that if they want to use them for evidence in a trial later on, then we can get them excluded. Example of, I'm going to skip ahead to creative approaches to accommodation. I was asked to speak about reasonable accommodation today. You can say that to them, but again, it doesn't mean that they're going to leave it out. The question is, can you ask someone who's a agent of your landlord, can you ask them to not bring their phone in and take pictures, or to just leave their phone outside? And the answer is yes, you can, but it doesn't mean that they're going to do that. And I don't recommend escalating the confrontation under those circumstances. Reasonable accommodation. So this comes from the theory that just because someone is disabled doesn't mean that they don't deserve equal enjoyment of their tenancy. If someone, and so this includes mental health disabilities, which means that they have a disability defined by the state, Specifically, it's a disability that that significantly affects more than one major life activity. And tenants are entitled to this right from application through eviction. From application through eviction, yes, from the time that they apply for their unit until the time that they are evicted. The accommodations or changes to policies or procedures, and that so some examples might be a later due date for the rent for tenants who have disabilities. But you probably won't get a lower rent or get it for them. They won't have make it so that they won't have to ever pay rent at all. You can ask for large print notices. You can ask for modified guest privileges to be sure that they have the care that they need. Their caregivers or service providers are allowed to enter. You can ask for a modification for a service animal, emotional support animal. You can also ask for a number of modifications to the premises so that might include a grab bar in the bathtub for someone who's having trouble getting out, ramps that make it hard for people to get in and out. Or if they can't hear, they can get a really loud smoke detector. So the request for reasonable accommodation or modification is presumed reasonable unless it puts an undue financial or administrative burden on the landlord, or if it requires a fundamental alteration of the nature of the provider's service, or if it creates a direct threat to the health and safety of others. The reasonable accommodation must have a nexus with the disability, and what that means is the accommodation has to solve a problem associated with the disability. The landlord can request medical verification, but that doesn't mean they have the right to medical records or specifics about the disability. You don't need to hand over medical records. A letter from your treating physician should be sufficient as long as the provider states a clear nexus. Now, what's really fun about this from my point of view is the landlord needs to engage in an interactive dialogue with a tenant who is requesting a reasonable modification. So frequently, if I'm working with a disabled client, one of the first things that I'm going to do is I'm going to request a reasonable accommodation. The sum of the request, or the undercurrent of the request, is going to be you're only trying to evict this person because of their disability. You need to figure out a way to accommodate their disability so that they can stay. And the landlord has to talk to me about that, or they may be subject to a wrongful eviction case. They might be putting someone out who's disabled because they're disabled, or there may be a very strong argument for that. And these are very valuable cases. I was asked about creative approaches to accommodation. How am I doing on time? 1 minute left. So really quickly, the most creativity that the accommodation requires is usually to get everyone to listen to one another and figure out what the actual pieces of leverage are, whose responsibility is what. Because at this point, I've been working with my client for several months now, perhaps, and the landlord's attorney, my client isn't speaking to their landlord, isn't speaking to the landlord's attorney, so the only thing that they're hearing from their landlord, they're hearing from me. And there is very commonly a point in every single case where one of my clients will tell me, "You don't work for me, you work for my landlord." And I often invite them to talk to the landlord's attorney and see who they think I'm working for. So that will involve me trying to convince the client that this is a thing that they need, and also convincing people to let some things go, because a lot of times my clients think the case is actually about something entirely different, about a conspiracy of various types of kinds. Pay your rent. Remember that I didn't get to talk about settlement agreements. what everyone's trying to do in this case, particularly what the landlord is trying to do, they don't want to go to trial. They never ever want to go to trial if they can avoid it. And their attorneys quite frequently do not want to go to trial either, especially in public housing cases, because they're getting paid a flat rate for a lot of what they do. So the more work they do, the less money they make. So what they're trying to get out of this is they want the client to be so scared that they're going to be evicted that they will sign a settlement agreement just to make the case go away. But what the settlement agreement actually does at its basis is it gives the landlord the right to evict the tenant without going to trial in the event that the tenant is unable to live up to the concerns in the settlement agreement. So a lot of times they're going to try to smuggle in terms. So I said they're saying the case is about one thing, but really there's several things going on. So they're also going to want payment of the rent in it. They're also going to want taking out your garbage all the time. And they're going to try to put things in about the lease, following the lease. And depending on how good the case is, I'm always trying to get rid of things that are going to be permanent or that are going to be long-term. So things to look for. Tenant must obey house rules. Yes.
You're talking about the word settlement in the end of the situation, but what is the difference between the settlement and the stipulated judgment? Because I went through that and I did not get a settlement. I got a stipulated judgment. Can you address that, please?
They're interchangeable terms for the exact same thing. I always want it to be called a conditional stipulation for the entry of judgment. They always want it to say a stipulation for entry of judgment, just as though you're admitting that you did something wrong, no matter how clear the thing may be on it. They're the exact same thing, though.
And the dismissal that I received, I won, of course. And and it just happened too. The dismissal was given to me was the request for the dismissal, but I did not assume that was logically the real settlement until I went to the courts on McAllister Street and they gave me it stamped. So is there anything beyond that? Like once it's stamped and filed by the clerk, is that finalized? Because it says request on the paperwork and request is different than final settlement. Can you address that?
So the request for dismissal is usually put forth by the plaintiff of a case, the person who started the case and the whole point, and they're saying, I don't want to do this case anymore. So the court just dismisses it based on that request most of the time. The stipulation is something else. The dismissal comes after the stipulation most times.
Is the stipulation adhered to after the case has been dismissed?
The case is usually dismissed after the stipulation has been fulfilled. So after both sides have done everything that they agreed they would do, at the end, and usually that's the expiration of a time period, that's when the landlord is supposed to dismiss the case.
So the stipulation is before the dismissal because you have adhered to the proper terms in that. And so
the stipulation just means agreement.
Okay. Thank you very much.
Sure enough.
If you're a resident in a house, let's say like a family house, can the landlord, the brother in my case, evict me?
I'm not sure from that little bit of information.
I don't know. Good question.
But that's probably broader than a question that I can answer at this event. Next speaker.
We're going to be grouping all of the housing questions together at the end of Kristen's presentation. So is this your last slide?
Yes, I'm done. I think the last slide says.
Okay, we'll just grab this one question, and then for those of you asking questions online, we'll be adding those to our Q&A.
Can a landlord evict a tenant because No, can a tenant be protected by SSDI if they're receiving SSDI from eviction?
Depends on if they're paying their rent or not.
They're paying their rent on time. They're keeping the property clean. They don't make loud noises. Everything is within the law.
They can't evict them just because they're on SSDI. That's discrimination.
Okay, no, does SSDI protect the tenant from being evicted?
No.
Oh, really?
Thank you so much, Abel. We'll go ahead and have Kristen come up from the Tenderloin Housing Clinic. And then Kristen, feel free to go ahead and adjust the mic to a different height. And then the click.
Put it back in there. I just don't want to drop it. I'm sorry. I don't trust myself. Yeah, that'd be rad. Is the presentation in there? Cool. Hello. Did it go? Okay. Oh, other way. You said the down arrow. Okay. Hello, my name is Kristen Acevedo. I'm here, I'm representing the Tenderloin Housing Clinic, which is a nonprofit housing organization in San Francisco, California. This section is going to be more about securing housing and the obstacles to housing for our seniors. In my building, I manage a senior building called the Ramon Hotel for Tenderloin Housing, and it's for tenants that are 60 and up. So we'll get more into that. Okay, cool. So I work in what you would call permanent supportive housing, PSH. And my organization is Tenderloin Housing Clinic. So the Tenderloin Housing Clinic, again, is a housing organization, and they have over 20 permanent supportive housing sites. They're SRO hotels, which is called single room occupancy, across the Mission, Tenderloin, and South of Market neighborhoods in San Francisco. We specialize in adults experiencing homelessness, long-term or chronic homelessness, mental health issues, trauma, and substance use issues. We are firm believers in the housing first model. Going back to homelessness, we feel that you cannot get stable without housing. That is the key to getting stable. That's with your mental health, your physical health, everything, behavioral issues, finances, getting a job, employment, everything, all of that. It can't be solved until we get you housed. And so that's what the housing first model is. And then we utilize harm reduction principles. Again, we work with substance use and with long-term and chronic homelessness and mental health issues, that's obviously going to lead into behavioral issues. So we tried our best to meet our clients where they're at behaviorally. Let's see. Single room occupancy. So that is called an SRO. And usually what that entails is a room, normally that it's unfurnished. But at THC, we give you a dresser and a bed, and then we have our support services team to welcome you with a welcome kit. Communal spaces include a kitchen, a TV room, kitchen, bathrooms are communal spaces, and television rooms, and yeah, those are all monitored. Those are all monitored communal spaces. You got to be mindful of that. We have our on-site case management team, our on-site property management team, janitorial, maintenance services. We have, depending on the hotel, some of our hotels have 24/7 desk clerk assistants, and we have guests signing in and out, monitoring the wellness. So we're logging tenants as we see them. We do have a very transient population and very vulnerable population. So if we need to go looking for you, we go looking for you. So these are some of our programs at THC. We have master lease housing, continuum of care. Continuum of care usually entails a diagnosed mental health condition, HIV positive tenants, a lot of diagnosis in there. We have our veteran affairs for supportive housing. That's our VASH. We call it VASH. Exactly how it sounds. The Housing Ladder program, that is your opportunity to move up in the program, and that's more hands-off case management. More your behavior has been stabilized. You know, I tell my tenants in my master lease and COC buildings, if you want to move up, if you can make it here, if you can abide by these rules, and you can, you know, keep everything in check here with this on-site team, there's no doubt in my mind you can make it happen in the Housing Ladder program. But we got to get you stable here, and we got to keep you housed here first. And then the Ramon Hotel, that's our senior building. And that's one of the buildings that I manage for tenants over 60 years old. Tenderloin Housing Clinic. Yes. Any other questions? Cool. All right. Let's see. Wow, it's hot in here. Sorry. Obstacles to securing and maintaining housing. There's a reduction of affordable housing due to increasing real estate. I'm sure you guys have been on Zillow and checked out our property prices. It's pretty insane. And then on top of that, we have an aging population. People are living longer. It was discussed earlier that our population of 60 and over, and then even 80 and over, is going to increase significantly in the next 5 years. These are unprecedented levels of housing, special housing needs for people with disabilities and people over the age of 60. Let's see. Cost of living is gradually increasing more than Social Security income, disability, retirement. And then, of course, all of these impact mental health with our tenants. And so we're going to go into mental health. We mentioned it before. So there's a lot of mental health issues that we see with our seniors in our SRO communities: loneliness, self-isolation, depression, hoarding, cluttering, and just anxiety overall. The anxiety around gradually losing your independence. Memory issues. That usually opens up a can of worms, because that usually leads into, well, what else am I forgetting? Oh my gosh, I forgot this one thing. What else am I doing wrong? Back to what Dr. Duong said, a lot of times our seniors don't realize when they're slipping. They don't notice it. It's like you're too close to see it. And that's why our on-site support services team, our case managers, and our on-site supportive housing manager, that's why we're there to be vigilant and offer that support and look out for you and have your back and be that support system for you. Let me see. Let's see. So a part of our support services, obviously we have our on-site case management team. I'm the support services manager, so I manage 11 case managers across our sites. And what that looks like for seniors is vigilant case management style, very observant, sharing your observations with your tenants, noticing those little changes in behavior. And, a lot of times we look for the big things, but it's a matter of, are they leaving the house as often? Are they coming to coffee hour as often as they normally are? Their mood, are you more irritable now? Share more about that. Depression is a huge thing. I'm tired. Having my tenants tell me that they're just tired and they don't want to do it anymore. A lot of refusing care. That's another popular one. And the best thing that we can do is just share, to be present. You're here now, and we're safe. We have a roof over our head, and we have some services available. And so we have, again, our front desk clerk is assistance 24/7. We have our daily wellness check log. We have monthly habitability inspections, and that's when we go. We post a month in advance, and then we give reminders, of course, 24 hours prior. And we go in and we make sure that you're in DPH compliance, Department of Public Health compliance. Is your door opening at a 90-degree angle? Clear paths to the windows, clear paths to the sinks, clear paths to the bathrooms if you have a private restroom. And that's a safety thing. And, I tell my tenants, if something happens to you and we need to go in there and get you, can I go in there and get you? And if there's no clear paths, or if for people who use, if there's needles everywhere, That's not safe. And so what we do is we meet them halfway, and we give small obtainable goals, and we give them the tools to succeed. We hold tenant meetings. We have tenant enrichment, and we'll get more into that later. And then community volunteer opportunities, and of course, utilizing day facilities. I love day facilities. Stepping Stone, OnLike has a facility. I love day services. I really do. It gets tenants out of the neighborhood, away from their usual environment. And also it surrounds them with people who are just like them. And that's another thing too that we got to remember in our senior housing is, yes, our tenants have probably outlived everybody in their lives. And then I think it's really cool to remind them that you're surrounded by a bunch of other people who also outlived everybody. You guys should, be friends. It's never too late to be friends. So that's my approach. Anyways, let's see. Tenant enrichment. So every week we have a coffee hour and we have a food pantry. Not at the same time. Two different things. We have our monthly calendar distribution. We have a birthday party. And all of this also helps keep track of time too. Board games and bingo events, I talked about that earlier and how useful that is to keeping tenants engaged, keeping your brain engaged, and making sure you're not complacent and you're not complacent. Is it complacent? Yeah. Making sure you're not complacent and you're not falling behind and you keep chugging along. We have watch parties where we all gather around and we vote on a movie. Last month it was Men in Black. It was awesome. We have life skills workshops. And that could be how to clean your room, like how to keep up. Let's see, what methods are you using to stay on top of your medication? Talk about your relationship with your IHSS worker, your in-home support services worker, your homebridge worker, what works for you, what doesn't work for you. Let's see, what else? Hygiene, keeping up with hygiene. And then also talking about sexual health too with our elderly population. It is important. It's very, very important. We have quarterly tenant meetings where tenants can bring issues, questions, suggestions, or concerns to our team and make sure and we talk about it, make sure it gets addressed. And then also we have leadership opportunities for our tenants and we can become a tenant organizer. And tenant organizer is exactly how it sounds, where they organize the tenants, we get their opinion, we get the feedback, and we're trying to create that flow, improve that flow of communication between our service providers and our tenants. So unassisted living tenant responsibilities. So Tenderloin Housing Clinic is independent living. You got to be able to manage your basic finances. You got to manage your healthcare appointments and medications. You got to maintain basic habitability standards. You have to abide by terms of the lease, and you have to be respectful towards on-site staff and your neighbors in all communal spaces. With that being said, we do have some services available to help you maintain that independence and keep you here longer. Again, our on-site support services team to help address any concerns related to your well-being or your housing. The supportive housing manager. We have our Tenderloin Housing Clinic has a partnership with Human Services Agency and the Department of Homelessness and Supportive Housing. And we have the Collaborative Caregiver Support Team Program, which is in-home support services and the Homebridge Caregiver Program. So we have monthly meetings to make sure that our tenants and their service providers, everything is going well, everybody's passing habitability, health is okay, health insurance is fine, all of that. There's also in San Francisco, we have a HealthLink is one example of how we can connect tenants to primary care without, with those mobility issues, where they come on site and they have their charts and they bring primary care to us. HealthLink is a good one, and linking them to Institute on Aging is another great resource. Unlock services, adult day centers. Stepping Stone, love Stepping Stone, and they have art therapy. They have physical rehab areas. It's awesome. And then money management, paying your rent on time and in full. We can do money management referrals. We have representative payees. We can hook you up with Conard House, Bayview Multipurpose Senior Services. Tenderloin Housing Clinic has their own rep payee services, and if you want to keep it in-house. But for our seniors, I like to do long-term sustainable solutions when it comes to their finances. So usually I'll do senior specialized care when it comes to their finances and medical care. Right on. And then, of course, the reasonable accommodation process. I'm going to go a little bit more in depth with that. Let's see. Some examples that I see at the Ramon Hotel as live-in caregivers, emotional support animals, access to more sunlight. So having, getting your room changed to a more, south facing, right? Something like that. South or southwest facing. Yeah. Access to more sunlight to ease that depression. And then increased wellness checks. If your health's not in the best condition, or if you have excessive worry and you want to hurt yourself or something like that, we'll put you on the list and we check on you every single day and we just make sure that you're okay. Right when I clock on and right when I clock off. Alterations to, these are more physical ones. So grab bar installations, alterations to ramps and thresholds, walk-in showers, and access to ADA elevators. The Ramon already has an ADA elevator, and that's what makes our hotel so special. Everywhere else has the one from the 1920s or something, and it's very difficult to work with. But at the Ramon, we do have an ADA elevator, and it's the quality of life, having access to being able to get in and out of your dwelling, we take it for granted, honestly. American Disabilities Act, yeah. Let's see. And then finding the right fit. Sometimes it's not enough, and that's okay. But reasonable accommodations, it is a medical document, and with the supporting documentation, we can still submit an RA request and continuum of care supervisors with the Department of Homelessness and Supportive Housing. And this can even happen while a tenant is in the hospital or something like that. And we get that all the time at the Ramon, where someone ends up in the hospital and maybe the level of care that they need upon return, we can't give them that. And so what we do is we put it in an RA, and usually they'll find some type of assisted living, skilled nursing facility, long-term care, where they can settle. It's called aging in place, and that's where they can age in place. Let's see. I think that's it for me. Okay. Oh, Q&A.
Thank you so much, Kristen. I think it's important for us to understand that it's not, there are multiple housing options, and SROs are a thing that are worth looking into. All the speakers can go ahead and come on up. We have questions for most of you already, and we'll go ahead and start with some of the ones that have gotten on the list in the computer on the YouTube Live. Thank you for submitting those. Go ahead.
So one is specific about Tenderloin Housing Clinic, but is THC federal and state funded?
Is THC federal and state funded?
No, the answer is no. Okay. The others are more general. One is, I think this one came in for Abel, but what can a tenant do if they damaged their unit while experiencing a psychotic episode and were provided eviction notice for intentional damage to property?
So the tenant damaged their property while they were in a psychotic episode, and now they've received an eviction notice?
Yes.
I would take it down to the Eviction Defense Collaborative right now.
And then the other one says, can the landlord bring a third party to your rented unit, perhaps as a witness?
Yes.
Yes, they can bring a witness, a third party.
Okay.
All right.
In
It's on.
Oh, is it on? Can you guys hear me? In Tenderloin Housing Clinic, it is supportive housing. So there are, depending on the behavior and how egregious it is, there are steps that we take before eviction. It's about eviction prevention, housing retention. So if we see a behavior, say, at our buildings, you have to sign your guests in and out. Again, we work with a very vulnerable population. It's important to know who's in our buildings. And, the decision making, it's not always there. It's not always sharp. So we got to really monitor that and keep our people safe, keep our community safe. With all that said, say this behaviors are egregious, or not terribly egregious, but it's getting there. We have tenant meetings. So the on-site case manager will talk with you and say, hey, this was not okay, and this is how you fix it. If the behavior persists, you get letters from the property manager, the supportive housing manager. You get warning letters and you get written violation notices. And you go through a process. There's tenant conferences, and then there's housing retention conferences. And that's the last step before we go to a refer to legal. So there's a lot of steps, but depending on how bad it is, on how egregious the behavior is, I can count the number of times we went straight to legal. It has to be really, really disruptive or really, really dangerous. But when it comes to like hoarding, behavior, noise complaints, property damage, just, not being respectful to the spaces, usually we give a lot of chances at Tenderloin Housing Clinic. I can only speak for Tenderloin Housing though, not for general housing.
I can actually speak for a private landlord. I used to be a property manager at a private apartment building, and we had multiple tenants with psychiatric disabilities. We also don't really, we don't want things to go farther than they need to go in our particular case. And we had tenants who threatened me as the property manager, and really we just talked to your case manager because I just don't want to be in a violent situation, but I also didn't actually feel threatened, right? So it depends on the specifics, of course. Whereas another tenant assaulted a police officer outside, we didn't even have to really evict them. Like that was going to be the primary thing to address. So you do, even in private spaces, there is this span of what the situation is. We want everyone to be able to like stay in their apartment. As a landlord, it's easier to keep people than find new people sometimes. Sometimes it's the opposite though, so depends. Any other questions in the room? We haven't done the room for a bit. Great.
I have a friend who was accused of hoarding, and she did stay at the Royan, and she felt like she was excessively scrutinized, and that sometimes the inspections were arbitrary. Like one inspection meeting, they would get on her case about something, but then on another occasion, it wasn't even an issue. And she got a 3-day notice for the hoarding, and she had to go find a lawyer. And Eviction Defense Collaborative couldn't provide her with a lawyer, so they recommended that she go through Homeless Advocacy Project. But it was hell for her having to deal with an arbitrary property manager. What do you do to ensure that you hire property managers who know what they're doing and who, is willing to really work with the client, not just trying to get them evicted?
Overall, we try and take a collaborative, solution-oriented approach to, and that's even our supportive housing managers. That's why they're not even called property managers, they're supportive housing managers. And the Department of Public Health guidelines, because that's ultimately what the standard is of habitability, right? Is the clear paths I was telling you about earlier. Clear paths to the door opens at a 90-degree, clear paths to the windows, the sinks, fire detector in working order, screens on windows. These are all very straightforward, tangible, objective goals. So there shouldn't be a surprise around, it's not a matter of opinion of the property manager. It's either the unit is incompliant or it's not. And then that's when our support services team, our case managers, that's when we break it down for our tenants. And usually I work piece by piece. I pick a section of the room and I say, let's fix this first. Then we move on to different sections of the room. But play it by ear. It's a case to case basis. I've had tenants who had severe hoarding and cluttering and a severe attachment disorder, and to save their housing, they just stepped aside and they said, "I can't look. Can we just deep clean it?" And I say, "Okay." And I sit with them in the hallway. We sit together and we just watch them do the deep cleaning. And we, the team that, at least for Tenderloin Housing Clinic, the deep clean crew that we have or we don't have, but we consult with this deep clean crew. His name's Bill, and he's super thoughtful in his approach. He saves family photos, IDs, any formal documents, anything that looks medical related or social security related. He'll put it in one bag. He puts personal things in another Ziploc baggie. It's very, very thoughtful. But it all depends. But regardless, the guidelines that these property managers are upholding, it's not a matter of opinion. It's very objective guidelines. And yeah.
Yeah.
So Sandra's a supportive housing manager with Tenderloin Housing Clinic.
Ultimately, this is on. Yes.
Yes.
Hello. Nobody, I mean, at least me being a supportive housing manager, we don't want to kick people out. We do really work with them. If there is an issue, there is a process for the tenant. We have a client communication form. If they're not happy with the response, can also get kicked up to a grievance. We also have visual aids to show the tenant as well, that DPH puts out. And it goes from 1 to 9, and it shows you like, okay, a 1 is great. A 9 is you definitely need a lot of help. So we can give that visual aid to show them. But all the people that we currently work in at my site, I don't work at the Ramon, and you mentioned the Royan. The Royan is in the Mission. I ultimately, I try my best to help people. I try to give them techniques of how to clean their place. I'm like, set a timer for 10 minutes. And if you do 10 minutes, then you're finished, cool. If you want to do another 10 minutes, go ahead, add another 10 minutes on. But a lot of times it takes a group to help you do this. And like Kristen said, we do have outside resources to help with deep cleanings. But yeah.
I mean, there is a reality just as the property manager. If I had gone by, I might have picked a different first step than the next person does for their first step. So there is going to be some human variability. I actually wanted to ask you, Joy, I know you had mentioned that one of the things you started doing was shopping a lot. Can you turn the mic on? Shopping a lot, and then next thing you knew, you had more things than you had room for. I'd love to know, what are some of the resources you've started using that help you, go back to that same pattern?
Hi. I'm extremely organized person, and everything is in containers, those Sterilite containers. And I'm not like mounds of stuff. Like my situation is really an organized situation, and the general population that I hear and I adhere to is like you have mountains of stuff and everything is just disarrayed, and that's not me at all. So I want to make that very clear here that my resources are basically me just having and going and renting storage was one of the things that I pursued. And I'm still in the process of, getting rid of stuff. But due to the fact that I'm organized, and I did have people come aboard, and luckily did not have to pay someone, because it's all about, well, we'll help you at the time, but it's going to cost you $400 for us to bring the people, with the truck and just unload stuff. But I didn't have to go that route. I've been doing it all myself, and luckily, but this was in the past and not now. But I still have storage to get rid of, and at my age, I don't need to have storage. But as far as the resources, MHA San Francisco, which Solve is representing, that is how I learned about being a speaker for Solve was through the hoarding and cluttering events that they had on a regular basis, and I attended those, and then I got involved in the yearly conferences that was going on and still going on that we have every year, and listening to people reading and just mind setting me that you've got to purge. You just can't hold on to anything. I believe that's pretty much what I did, but I didn't have to like hire help or hire. I actually had what do you call that? Supportive. It's not coming to me. The no. Something else. There was something else, and it's just not coming right now. But I was fortunate not to have, because people have to spend a lot of money, and I was very fortunate to be able to do it myself with very few people, and I also rented a U-Haul truck, and I did all that on my own, and I was a lot younger in those days also. Did that answer the question?
That was great. Yeah.
Thank you.
That was wonderful. MHA, Mental Health Association, they have chapters all across the country. And so you can find one in your state, but also they have county chapters and city chapters where there's in more populated areas. And they run fairly independently. So you'll have to search Google to find that. Wonderful. Did we have another question in the room? Yes.
I guess I had a question. I'm curious about maybe creative solutions for reasonable accommodations that are coming from a tenant, which I guess for lack of a better phrase, are not reasonable. Like for instance, like I'm a resident services coordinator. I work separately from the property management team. If like say a resident is requesting to move to a different apartment based on something they believe is happening and is by all appearances not based in reality, like it seems that there will only be an unsatisfying conclusion to going through the reasonable accommodation process. Do you have any experiences with kind of coming to some resolution that actually works for all parties?
As someone who has tenants come to her with these unreasonable accommodations, talk about it, have dialogue about it. One example that I could think of that's super common is that they don't like their neighbor, whether the neighbor is smoking or the neighbor has an annoying voice or their dog barks too much or something like that. We talk about it. Can you guarantee that the next neighbor won't smoke? No. Can you guarantee that the next neighbor won't have an annoying voice or just be annoying? No. But a big part of what we do is rooting them back into reality and the reality of the situation. And at least for my buildings, I remind them that, hey, this is an apartment. Like this is a building. This is communal. You have communal spaces and we live literally right on top of each other. This is what's to be expected. You're going to hear people. You're going to hear moving around. And unfortunately, you guys are allowed to smoke. We don't advise it, but you shouldn't smoke in your unit, but you can. And that's the reality of the situation is to talk about it. Okay, what is moving going to do? How is this going to fix the situation? And talking about what exactly is happening. I've had tenants say that they have people reaching through the walls. It's very real to them. Don't deny that reality. It is very real to them, but that's a mental health thing. And that's when we can talk more about that. How often are they reaching through the walls? What does that look like? Can you hear them? Can you see them? Can you feel them? Tell me more about that. And then that's when we loop in mental health services too.
I have we'll have two follow-ups to that, but if you could address this, Abel, when you add to that, or Christine, you might have something as well. For job accommodations, there's the Job Accommodation Network, which is a website you can access for free. You can call and get advice for free. Is there anything like that for housing? any sort of resource you'd recommend to help understand what is versus isn't reasonable? Because the non-reasonable example I always hear is an elevator in a building that they can't pay for an elevator. They're actually very, very expensive. But I don't really hear a lot of other examples of what's not reasonable other than what you've shared with me. But are there any kind of resources, kind of data banks of these are things that are commonly asked for? I don't know. Yeah, that's fair.
I guess in my line of work, I get a lot of accommodations that are unreasonable. Sometimes they want the DEA to come bust the whole building and remove the whole property management system. So for me, a lot of times it continues to be focused. The discussion is, well, do you want to stay here or do you want to move? Because if that's really the problem, then you should think about moving. They almost always want to stay. So it's about finding that. But my responsibility is really to try to get my clients what they want. I'm not really looking for the best solution for them. And a lot of times it ends up being that's just something you're going to have to figure out how to live with. I have a lot of those kinds of conversations.
We'll go ahead and do your question and then we'll head across. Oh, I'm so sorry. We had Avonelle. Go ahead.
I just wanted to add that oftentimes a person is neurodivergent or on the autism spectrum, which is sort of a thing, where saying that they can be sensitive. I am on the autism spectrum, and having smoke next to me is a reasonable accommodation. However, it may not be a legal reasonable accommodation. And some of the things that can be helpful is, suggesting, just especially if it's noise, working with that person wearing earplugs. I have earplugs in right now. And these are things that, we have to be mindful in terms of language. Even if it's not a legal reasonable accommodation, it is a wellness reasonable accommodation. And so even if you move them to a different apartment, yes, there will be noise, there will be smoke. Of course, you're not supposed to smoke. But how can we work with that person so that they're able to live based on their individual needs? And that is reasonable. So, especially in housing, I do not live in an apartment. I live in a home, and I have noisemakers around my house because I just have neighbors right now who play a lot of music. And I have spoken to the landlord. It's 8 o'clock, or 10 o'clock, I think. But I also have noise machines around my home because it's my responsibility too, for my wellness in living. So I think that, as we discuss, how do we support persons over the age of 65 in living an overall wellness, we also have to consider how can we support them in increasing skills and tools so that they can implement into their lives that their ask, which is reasonable ask, can assist them in increasing their wellness.
And I think Avonelle actually touched upon how powerful the interactive dialogue can be, because it helps you really. Sometimes people think this is the solution to my problem, but it's, to Kristen's point, it's not always the actual solution to the actual problem. So a lot of the things that you suggested, like the noise machines, those can come up as solutions in that interactive dialogue, which is a legal phrase they're used in a lot of legal contexts. So that back and forth and really staying focused on what are we actually trying to solve for is where you can come to the best outcome. You had a question?
Yeah, Ellis Act evictions and extra protections that disabled people have and how that actually plays out.
Can you just repeat what that was?
Question was, Ellis Act evictions, are there different protections for disabled people and how does that usually play out?
Thank you.
So generally, what's available for disabled people in San Francisco who are who they're trying to get rid of, evict based on the Ellis Act is they get more time and they get a little bit more relocation money. But other than that, there's some other stuff we can do to make it take longer and get them better deals, but it's proprietary information.
And we have, I have one up here and then on the computer, go ahead. Yeah, we're running out of time, so we're just going to take the question in the back and then we'll finish up with one related to making sure you pay your rent with Able. Go ahead.
Okay, so one of the questions that came in through the chat is, it's very specific, I think to Kristen maybe, but can you describe how HealthLink partnership works? Are there individual referrals for HealthLink, or does a nurse or the treatment team come out weekly for home health support?
So HealthLink is just one example of one of the resources and referrals that we make. And HealthLink is an individual resource, it's an individual referral. Another example would be the permanent housing advanced clinical services team, also known as the FACS team. And then through the UCSF behavioral health roving team, that's another clinical service. That's another way to bring healthcare to the house or to the home. Unlock Institute on Aging, they send out case managers into the field, advanced social workers into the field it's awesome. They have these tablets that can load up a client's medical history, insurance info. It's amazing. But HealthLink was just one example of those resources, but there's quite a few.
Thank you. And actually, I'll close off with 211 is a tool that you can use for wherever you are in the U.S. You can use 211 usually, and they will start, point you in the direction of some potential resources. I will say not all resources give robust descriptions, so take a deep breath and get ready for maybe a few phone calls until you get to where you're trying to go. But other than if you don't have internet access, that would be a recommendation I would make to get started. Thank you so much to all of our panelists. It was great to have a range of things to discuss today related to psychiatric disabilities in older adults, and we appreciate your time. We're going to go ahead and have Alan close us out with some closing remarks. Thank you. Sorry.
Again, thank you very much for coming to our seminar. As a reminder, please complete and return your evaluation forms before you leave. For remote participants, you will see a link to our online survey in the chat. For those who wish to get continuing education credit from the State Bar of California or the California Board of Behavioral Sciences, please turn in your evaluations and pick up your certificates at the table outside. If you have any questions or comments on today's seminar, please contact People with Disabilities Foundation at 415-931-3070 or email at info@pwdf.org. We hope to see you at future events. Please sign up for our e-newsletter on pwdf.org's homepage or at the table in the back to be the first to hear about upcoming events. And once again, have a great evening, everyone. Thank you.